Your Excellencies, distinguished colleagues, ladies and gentlemen, good morning to all of you joining us in person and online. Welcome to the 2024 IVI Global Council meeting. My name is Colin McCann and I am the moderator for today's program. We open today's first session with welcome remarks from Dr. Opart Karnkawinpong, IVI Global Council President, Permanent Secretary for the Ministry of Public Health in the Kingdom of Thailand. Please welcome Dr. Opart.
Dr. Jerome Kim, Director General of IVI. Mr. George Bickerstaff, Chairperson of IVI Board of Trustees. Dr. Ander Nordstrom, Chairperson of the IVI Global Advisory Group of Experts, esteemed members of the IVI Global Council. Good morning. First of all, I extend my warmest welcome to the distinguished members of the IVI Global Council, the IVI Secretariat, and all participants, particularly those who have traveled a long distance to attend this meeting. It is also both an honor and a privilege for Thailand to be the host country for this important meeting, which provide opportunity for the IVI Global Council member to engage in meaningful discussions, exchange ideas, and collaborate on advancing vaccine research, development, and implementation, and to address critical issue of vaccine equity, access, and capacity building at global, regional, and national level. Colleagues, I would like to highlight some of the significant global threats. We have lesson learned that the COVID-19 pandemic underscored the need of science, solidarity, and equity in addressing global challenges. The pandemic has also alarmed the urgent need for a more equitable global health system, where vaccines and life-saving treatment are accessible to everyone. Apart from COVID-19, the Mpox outbreak is currently a global health emergency. With the growing spread of the virus, we need to further scale up coordinated international effort to support countries in ending the outbreak, ensuring the available of and access to Mpox vaccine is a key recommendation by WHO to address with the widespread of the Mpox virus. Another threat I would like to mention is leptospirosis, which is considered one of the leading zoonotic cause of morbidity and mortality, especially in underserved areas with limited surveillance. There are nearly 59,000 deaths attributed to leptospirosis annually. The real figure may be higher due to potential misdiagnosis. Thus far, many approaches have been used in an attempt to develop an effective and broad-spectrum protective vaccine against the disease for humans. All in all, we realize that vaccines are among humanity's most effective tools humanity has ever developed for prevention and control of infectious disease outbreaks, as well as saving lives. Distinguished delegates, Thailand has aligned ourselves with global health policies in the delivery of public health care, including vaccine for eligible population pertaining to international public health and communicable disease. Thailand's accession to IVI will enhance our collaborative effort with this reputable organization and support our role in strengthening and expanding vaccine access. I am confident that robust collaboration between member states and the IVI will bring us significant opportunities for vaccine research and development. This will support countries in human resource development efforts and addressing the vaccine development gap in timely manner. By our collaborative effort in vaccine research and development and accessibility, we can contribute to improve health outcomes for our population and our global community, enabling millions of people to live healthier and long lives. As we are gathering in this meeting, we realize the critical work that needs strong cooperation. I am certain that our discussion and recommendation of the IVI Global Council will provide valuable input for IVI board to advocate the essential vaccine development and innovation. Our strong collaboration is crucial to tackle complex health challenges. In addition to the technical matter of vaccine development and the implementation in this meeting, we also pleased to offer a site visit at the government pharmaceutical organization in Saraburi province, which provide us the opportunity to explore one of the main vaccine and biological plants in Thailand. I would like to conclude my remarks by express my gratitude for your time and commitment. I look forward to a fruitful discussion. Distinguished guests, please accept my apologies as I need to leave the morning session of the meeting for urgent appointment called by the Prime Minister at the Government House. Please allow me to introduce Dr. Sopon Iamsirithawon, Inspector General of the Ministry of Public Health of Thailand, to conduct the meeting on my behalf. I will come back of the meeting as soon as the meeting with the Prime Minister is finished. Thank you for your understanding. Thank you so much.
Thank you, Dr. Opart, for your welcoming remarks. Next, I would like to invite IVI Director General Dr. Jerome Kim to deliver his opening remarks. Please welcome Dr. Kim.
Honorable Representatives, Global Council President Dr. Opart Karnkawinpong, Your Excellencies and distinguished guests. My name is Jerome Kim, and I'm the Director General of the International Vaccine Institute, or IVI. On behalf of the IVI Global Council Secretariat, it's my honor and pleasure to open the 2024 IVI Global Council. In the Global Council's virtual meeting in June, Thailand became the first IVI member state to assume the Global Council presidency and appointed Dr. Opart, the Permanent Secretary of the Office of the Permanent Secretary at the Ministry of Public Health, to serve as the Global Council President. I would like to thank Dr. Opart, the Ministry of Public Health, and the Kingdom of Thailand for their role in hosting and leading the Global Council this year. Thailand's leadership marks a significant milestone for the Global Council. The commitment and guidance demonstrated, particularly in hosting and leading the Council meeting in Bangkok this year, have been invaluable to our collective efforts. I would also like to express my sincere gratitude to all the representatives from IVI member states who attended this meeting in person. Your time and dedication are deeply appreciated, and they've been critical in helping IVI make significant strides in advancing our shared mission. As we gather for this meeting, I would like to reflect on the numerous global health challenges facing the world and what the Global Council and IVI can do to make a positive impact. This year, we faced a resurgence of Mpox. But this isn't the Mpox of the 1950s, or even the Mpox of 2022. The pathogen has changed, and the threat it poses has changed. In August, the World Health Organization declared the ongoing Mpox outbreak a public health emergency of international concern. Africa's CDC declared Mpox a public health emergency of continental security in Africa in August, reporting over 17,000 cases and over 600 deaths between January and August. And I should note that Africa's CDC's numbers come with a caveat that only 3% of the cases are actually probably being detected, and only 18% of cases are being tracked. So the problem is possibly a lot bigger than we expect. Simultaneously, the world is experiencing its largest ever outbreak of dengue fever, with over 12 million cases and 8,000 reported deaths in 2024, most of these occurring in Latin America and the Caribbean. In addition, cholera outbreaks across Africa, the Middle East, Central and South Asia have caused an estimated 342,000 cases and over 2,400 deaths. The global stockpile of oral cholera vaccine managed by WHO was depleted in March, and the WHO has been able to provide only half of the 34 million vaccine doses requested by the countries experiencing outbreaks. Violent conflicts, climate change, and antimicrobial resistance, or AMR, are accelerating the spread of infectious diseases, which principally threaten the lives of the world's most vulnerable people. Nearly 50% of deaths in low and middle-income countries are caused by communicable diseases. We know that vaccines and vaccination are among the most effective and valuable tools available for protecting human life and alleviating poverty. Furthermore, transferring vaccine technologies to developing country vaccine manufacturers is a proven method for sustainably increasing global vaccine supplies. Yet, in the world's major multilateral assemblies, the World Health Assembly, the United Nations, the G20, we observe the hesitation and even rejection by some countries to include vaccine technology transfer provisions in the long-delayed WHO pandemic agreement, the UN's upcoming political declaration on antimicrobial resistance, and the Global Alliance for Regional Production and Innovation recently proposed by the G20 president, Brazil. What makes IVI unique among international organizations is its specific mandate and capacity to discover, develop, and deliver vaccines for global health, and to share that technology and know-how with the world. In the IVI Global Council, we have a multilateral advisory assembly composed of member states that endorse IVI's mandate and recognize the value of vaccines and vaccinations to global health. This shared endorsement of IVI's mandate is the Global Council's source of strength, legitimacy, and influence. With a unified voice, the Global Council can recommend how IVI should utilize its mandate and technical capabilities to advance global health priorities. The member states of the IVI Global Council have the ability to recommend IVI as a reliable and effective partner in multilateral organizations where hesitation and obstruction prevent the advancement of vaccine technology transfers. In closing, let's remember that our collective efforts and unified voice can drive significant change. By leveraging IVI's unique capabilities and the Global Health Council's influence, we have the power to build a healthier and more equitable world. Thank you.
Thank you, Jerome. At this time, I would like to invite the chairperson of the IVI Board of Trustees, Mr. George Bickerstaff, to deliver his remarks. Yes, please.
Hello, everybody. Honorable representatives, Dr. Opart, Thailand, Your Excellencies, thank you very much for hosting this in such a beautiful location and colorful. It's extraordinary. My name is George Bickerstaff. I'm the chairperson of the International Vaccine Institute. The International Vaccine Institute was founded 30 years ago, sponsored by South Korea. And since that period of time, we've been able to accumulate 27 state parties. Of those 27, today, 15 are represented. 12 of you are here, and 3 of you are online right now, so roughly half. In total, though, we have 42 parties that have signed on to us as the International Vaccine Institute. Our mission, as Jerome told us, is to basically stop infectious disease, people from suffering from infectious disease using vaccines. A statistic that I learned a few years ago is that more than 10 million people die every year because of tropical diseases and infectious disease. COVID was devastating. Less people died in COVID than die every year from the things that we're trying to prevent. We're making great progress as an organization. There have been over 3 vaccines that have been developed by Jerome Kim and his team at IVI. And we expect to do more in the future as things come. We're growing rapidly from a relatively small organization to an organization with more than 250 employees. And we're now in 4 regions, Asia, Europe, and Africa, with Rwanda being our new flag state in Africa. This is extraordinary growth for us. The key, though, is for us to use you as our partners, we're partners, to come up with more ideas, approaches for vaccine development and distribution. We are partners. You're our customers. You are a partner. We are your partner. We need to continue the progress of developing more vaccines for more people in more locations, and you're a critical component of that. And I'd like to thank you for that very much. We plan to have another 5 countries join IVI in the next year or 2. Canada, France, Uganda have all said they'd like to join us and will within the next year or 2. That means we'll have, at that point, 2 G7 countries. We'd like to get all 7 G7 countries, and we're hopeful to do that. We've got a lot of work to do still, much work to do. The challenge is huge. We're still just tiny. We do $100 million of revenue every year. That's a 33% CAGR, compounded annual growth rate, since Jerome came into position. And we expect that to continue. We hope that continues, and that'll continue with the help and support of everybody here. Jerome and his team have done a tremendous job. Jerome travels tirelessly. I never know where he is at any one time. He calls up and maybe he's in Stockholm, maybe he's in Rwanda, maybe he's in Kenya, maybe he's in New York, travels constantly. And he does that for all of us to keep things together. Thank you so much. Our job's to listen here, to take notes, to get your support. But if I could say one fundamental thing, and I hope everyone takes away, for us to learn together and to make new friends. And all of you are our friends. Thank you so much.
Thank you, George, for your remarks. At this time, I would like to invite the chairperson of the IVI Global Advisory Group of Experts, Dr. Anders Nordstrom, to deliver his welcome remarks.
Thank you so very much, and a big thank you first to the government of Thailand for hosting us here. It's always a pleasure to come back to Thailand and to Bangkok. I will say a few words about the Global Advisory Group of Experts, mainly to introduce the group to you and our function. We are a small group that was invited by the board to provide advice both to the board and to the secretariat in terms of the more big picture strategic direction of IVI. We are a small group of former ministers of health, foreign affairs, senior leaders from private sector, and now we've been also joined by 2 former heads of international organization. My own background is that I used to be the Swedish ambassador for global health, based in the Ministry of Foreign Affairs in Sweden for 13 years. Today, I'm associated with the Karolinska Institute in Stockholm as a senior advisor. I have 3 of my colleagues sitting here from our group. We're very happy and fortunate that we are actually going to meet back to your meeting. So we're here today to listen to you, as also a background for our discussions that will take place tomorrow. Our role, as I said, is mainly to provide advice from looking at the international political landscape, what is happening right now, how to position IVI in the international landscape of other international actors. And also we're going to have some discussion about what does the economy look like today, the business opportunity, as that is also going, of course, have an impact for IVI. As the chair was saying, IVI is in a time of expansion. I'm delighted that we are hosting the European office in Stockholm since now a couple of years. But I'm possibly even more delighted that IVI now is opening up offices in Africa. So one big question for IVI is, of course, the expansion. How quick and where? And I think that is, again, something we will discuss and, from our perspective, provide some advice. I strongly believe that IVI is quite a unique organization, both being an international organization with the state parties, but also in terms of the scope of the work. It's not just talking about new vaccines, it's not just talking about vaccine production, it's actually doing it. It's a hands-on organization providing technical support, collaboration with countries on vaccine development, discovery, clinical trials, but also training of people. And I think that's quite a unique position that is in high demand right now across the world. So we are very much looking forward just to listen to you today. And hopefully we will be able to share our deliberations, conclusions, views also with you after our meeting tomorrow. Thank you so much.
Thank you, Dr. Nordstrom. At this time, I would like to invite the Global Council representatives to provide brief self-introductions to the group. We will begin in alphabetical order with Global Council representatives attending in person, and then those joining us virtually. We will begin with the representative of Bangladesh.
Thank you very much. Good morning to all. I am Dr. Shibbir Usmani, Joint Secretary to the Government of Bangladesh. I am working in the Public Health Department, Ministry of Health and Family Welfare. Thank you.
Thank you. Good morning, everyone. My name is Jimmy Martin. I work for the national government in Ecuador, head of national research in the Ministry of Public Health. I have a background, a PhD in public health, and I'm very glad to be here sharing this opportunity with all of you. Thank you.
Good morning to all of you. I am Meera Srivastav. I am Joint Secretary in the Ministry of Health and Family Welfare, Government of India. I am the head of the Immunization Division, and I am looking forward for the interaction today to learn and take back all my learnings to the country. Thank you very much.
Good morning. My name is Dr. Michael Luciola from Kenya. I head the Kenya Biovax Institute, the institute that's responsible for the manufacturing and commercialization of human vaccines in Kenya, in the region, and hopefully in the continent. I'm looking forward to the interaction during this council meetings, and it's a pleasure to be here. Thank you.
Good morning, everyone. I'm honored to attend the global meeting of IV. I'm the ambassador of Mongolia to Thailand, and also a permanent representative to the international organizations based in Thailand. Thank you.
Good morning, all. My name is Rahim Shah. I'm the Chief Biological Vaccine Production Division, and also leading the messenger RNA technology transfer by MPP. And thank you all.
Good morning, everyone. I'm Professor Major General Amir Ikram. I'm the former Executive Director of National Institute of Health in Pakistan, but currently I chair the Definite Advisory Board as well as I'm Strategic Advisor with INV. I have been a member of the Gavi board, and currently I'm in the governance team. I also am a member of Strategic Council of Partnership for International Vaccine Initiatives, as well as closely work with SEVEN. So it's great to be with all of you. Thank you.
Good morning, Honorable Representative. I am Dr. Sopon Yamsri-Thawan, Inspector General for the Ministry of Public Health Thailand. I have experience in working on the communicable diseases such as COVID-19, vaccine preventable diseases, and also Mpox recently It's my pleasure to meet you all. Thank you.
A very good morning. My name is Nakorn Premsi. I am a director of the National Vaccine Institute in Thailand. We are working together with Dr. Opart and Dr. Sopon over here in supporting of the Global Council. And NVI, the National Vaccine Institute, is a partner of IVI. And I also serve as a member of board of trustee of IVI as well. Welcome to Bangkok.
Good morning, everyone. My name is Yu-Kyung Lee from Korea. I'm charging Director of Vaccine Development Division. First of all, I'd like to extend my heartfelt congratulations on the successful organization of today's in-person meeting. I share in the belief that addressing the next pandemic and advancing global health requires innovative approaches and necessary reforms. It is my hope that today's discussion will serve as a crucial milestone in shaping a better and more resilient future for global health. To make the most of this opportunity to drive meaningful changes. Thank you.
Good morning. I'm Dr. Tushani Dabrera. I'm the Deputy Director of the Epidemiology Unit of Sri Lanka, which will become the CDC in the near future, CDC in the country in the near future. And I'm the focal point for leptospirosis as well. And I'm glad to be here in this lovely city and country and amongst you all. Thank you.
Good morning. I'm Dr. Nadia El Marzouki. I'm the Director of the Public Health and Prevention Department in the Ministry of Health in the United Arab Emirates. I have vast experience in public health aspects, especially in communicable diseases and vaccines. Glad to be here and looking forward for the fruitful discussions. Thank you.
Good morning. I'm Layla Al-Jasmi, Head of Communicable Disease and Immunization Section from Ministry of Health and Prevention, United Arab Emirates. It's my pleasure to be with you today.
Good morning. My name is Nurmat Atabeka from Uzbekistan. I am first Vice Chairman, Senate Epidemiology Committee, Minister of Health. Thank you very much.
Thank you, Global Council representatives, for your introductions. At this time, I would now like to invite Ms. Youngmi Cho, head of the IVI Global Affairs and Communications team, to provide an overview on today's agenda.
Good morning, esteemed Global Council representatives and speakers and guests. On behalf of the IVI Global Council Secretariat, I'd like to express our sincere appreciation to all the attendees and making time, your valuable time in attending this event. So to assist you, the Global Council representatives in adopting today's agenda, I will briefly outline the key priorities and goals of each session, so aligned with the main purposes and the roles of the Global Council. Since many of you are new to this Global Council, I hope that this overview will also provide you some clarity on the Global Council's rules of procedure. Okay. So in session 1, so following the adoption of the agenda, after this overview, Dr. Jerome Kim, Director General of IVI, will present IVI's strategic direction and priorities. Through this session, we hope you gain a deeper understanding of IVI's roles and activities in global health. Following the presentation, there will be a Q&A session to address any questions. So this is IVI, like a purpose of the Global Council. So I'd like to remind you that the IVI Global Council is currently composed of 26 state parties and WHO as members. And one of its primary purposes is to provide recommendation to IVI's management and also Board of Trustees regarding vaccine needs and solutions. So as an advisory body under IVI's governance, we seek the Council's support in enhancing IVI's role as an international organization, fostering global and regional collaborations and building capacity. So in session 2, after lunch, we invite Global Council members to provide their remarks on 3 key topics. First, each country's national policies and priorities on vaccine R&D and manufacturing. And then second, responses to Mpox emergency and enhancing global cooperation. And then third, any recommendations from our member countries for IVI's next strategic plan. So each representative may address one or more of these topics. So after the whole remarks, we'll have a coffee break. And after a coffee break, Dr. Douglas Shepard, Deputy Director General of Global Affairs and Communications at IVI, will provide a summary and conclusion. So I'd like to emphasize here that this is Global Council responsibilities included in the rules of procedure. So here I'd like to emphasize that one of the key responsibilities of the Global Council is to discuss and address the needs and solutions for vaccine R&D and capacity building. So by sharing each member country's national policies and priorities, we hope to strengthen international cooperation at the global, regional, and national levels. So additionally, I'd like to draw your attention to another key responsibilities of the Global Council, which is to election of 2 members to the IVI Board of Trustees from non-funding state parties. Currently, funding states has seats on IVI Board of Trustees, but through this Global Council, we elected 2 members. And last year in the inaugural meeting, we elected Bangladesh and Rwanda as a board representative among the non-funding state members. And then also we have as well the appointment of members from the funding state parties. That's also one of the key responsibilities. In session 3, will address global needs in tackling the burden of leptospirosis and the necessity of including it in the WHO's list of neglected tropical diseases. This discussion will be led by Dr. Sunet Agampodi, a research scientist and expert in leptospirosis at IVI, and the Ministry of Public Health of Thailand will also make a presentation on this topic. In this session, IVI will also seek, in session 3, member states' support for obtaining observer status with both the UN General Assembly and World Health Assembly. So we will just address our needs to gain your support for seeking this observer status. And additionally, we will discuss the presidency of the Global Council for 2026, because Thailand presidency is for this year and then next year. And then for the following year, we will need to have a new president. And also, lastly, we will seek your input on the location, tentative dates, and agenda for the next year's in-person Global Council meeting. So for your reference, the Global Council holds at least 1 virtual meeting and 1 face-to-face meeting each year, with the majority of the members constituting a quorum. So today, later on, we will have online participation of another 3, so 15, which constitute a quorum for both convening the meeting and also making decision-making. And lastly, I'd like to remind the GC members, GC representatives, that a field trip to GPO is scheduled for tomorrow. And the meeting point is in the lobby, and Colin will advise you more details tomorrow. And we really appreciate all the support and cooperation provided by the Ministry of Public Health of Thailand and also National Vaccine Institute team from Thailand. Thank you very much.
Thank you, Young Mi. Next, I would like to invite Dr. Supon to initiate the adoption of the agenda.
Thank you very much, Ms. Young Mi, for presenting the meeting agenda today. I would like to seek for adoption, but first of all, I'd like to ask, is there any suggestion or comment on the proposed meeting agenda presented by Ms. Young Mi? I see none, so the meeting agenda is adopted as presented. And for our participant who joining online, we still have 2 more, right? I would like to ask Mr. McCain, would you like to give a time for them to introduce themselves?
Yes, thank you, Dr. Supon. So we now realize we have 2 Global Council representatives attending online. So we'd like to start with the representative of Spain, if they're available. Yes, good evening, Daniel. I think we can hear you. Thank you, Daniel. At this time, I'd like to invite the representative of Sweden to make an introduction.
Thank you, Colin. So thank you for the invite. I would like to stand up to Dr. Opart and Dr. Supon, and of course to Dr. Kim. And I'm sorry that I couldn't be there with you in person, but I hope on the discussion here, even though some colleagues are online. I'm Dr. Johanna Rubin from the Public Health Institute in Sweden. Thank you.
Thank you, Johanna. I'd like to turn back over to Dr. Supon.
Okay, thank you very much, and we are very pleased to have all the representatives joining either online or in person here. Let's move to the next agenda item. Since we have limited time right now, it's around 9:40 a.m. And I think the next agenda item will be presented by Dr. Jerome Kim on the IVI strategic plan. Right? Yeah.
Yes, so at this time, we'd like to invite IVI Director General Dr. Jerome Kim to present the IVI Strategy and Activities Report on IVI in Africa. Please welcome Dr. Kim.
Good morning, everybody. Let's see. I think we might want to go to the first slide. Oh, maybe I can control? No. Okay. I think we can start here. Everyone here on the Global Council knows that IVI is a UN-chartered international organization founded by UNDP, but now a freestanding international organization with a mission to discover, develop, and deliver safe, effective, and affordable vaccines for global health. IVI has 258 employees working in over 50 sites in over 40 countries around the world. Together with our member states, and you can see the flags not only of the 42 countries in WHO, but the 13 countries whose accession is pending, And these include the countries listed there and countries that George had mentioned as well. With this kind of support, we hope that IVI's mission of discovery, development, and delivery and its capacity and capabilities to do technology transfer and to train the next generation of people to work in a sustainable vaccine manufacturing globally will help to strengthen the world's ability to deal with pandemic threats in the future. This gives you an idea of where IVI is, and you can see we started in Seoul in South Korea, 1997. And it wasn't until 2022 that the European Regional Office was founded in Sweden. And at around the same time, a country office was opened in Vienna, in Austria. Austria is now actually a formal member and funding member of IVI. This year, we plan to open the Africa Regional Office in Kigali, in Rwanda, and the AVEC Africa Project Office and Country Office in Kenya, in Nairobi. At the same time, a new development has been something that's called HKJC Global Health Institute. You can see it on the left-hand side underneath the Korean flag. That is the symbol for the Hong Kong Jockey Club. And I'm sure everyone's wondering what the Jockey Club has to do with global health. But the Hong Kong Jockey Club is a charitable organization. 90% of the revenue that it receives from horse racing and gambling on football, or soccer as we call it in America, goes to support the Hong Kong Jockey Club Charities Trust. And the Charities Trust has pledged $65 million over the next 5 years to support activities related to global health, in particular for IVI, around process development, which is a key pre-industrial step to technology transfer of vaccines to other locations around the world. So you can see now also the pinpoints mark some of the countries and activities that IVI is doing around the world, and you can see them in Latin America, Sub-Saharan Africa, South Asia, Southeast Asia. And this has been IVI's growth since 2015. George mentioned it briefly. We have expanded significantly, and you'll see in the strategy discussion how this is beginning to shape how we think about sustainability for IVI and its mission. You can see that IVI's total amount of funding and from different organizations has increased significantly. In 2015, 75% of our funding came from the Bill and Melinda Gates Foundation. Now, Bill and Melinda Gates, which actually contributes roughly the same amount, is about 14% of IVI's total funding. This diversification of funders has made it more complicated for our finance office to deal with the complexities of different reporting and things, but it also gives us a better sustainability, because no longer are we subject to a single funder's changes in their strategy, in their funding strategy. At the same time, we've significantly diversified the portfolio of vaccines that IVI works on. In 2015, we worked on cholera, typhoid, and dengue. And these legacy programs are actually very important. You'll see one of the impacts of this shortly. At the same time now, in 2024, we work on a significantly greater number of diseases. This diversification of the vaccine portfolio makes us look a little bit more like a biotech company, which we're not. I mean, we're not for profit. But if you think about having things in the laboratory, having things in clinical trials, having things that are approved, that are now being optimized, we begin to look like an organization, as we say we are, that thinks about vaccine development from end to end, from the laboratory through delivery. And this is what the people at IVI do every day. So 258 individuals doing the things in light blue. And all of these things are potentially transferable. So if there is a need for support at any stage along what we call the vaccine value chain, from discovery, development, delivery, and epidemiology and surveillance, then programs at IVI exist to do that. Whether it's the 1-week vaccinology course or the longer 2-week vaccine development course, which is a part of the WHO training hub, or the 3-week course in, we call it GXP, good clinical practice, good laboratory practice, and good manufacturing practice. So the GXP course is 3 weeks. And in addition now, there are courses that are actual physical training in manufacturing training facilities. And later this year, the Korean government, in association with one of the provincial governments, will open a regional regulatory training facility where courses will be offered in English for training in regulatory inspections. Something that is relatively unusual, and we're still waiting to see how this develops, but the facility is now ready. And as we start to think about how the Korean government or IVI can help in training different people in different aspects of the vaccine value chain, including regulatory affairs, then all of these things become very important. If you're curious about what IVI's vaccine portfolio looks like, then it's down below in the gray. And you can see under discovery, the diseases that we work on. Development, again, these are vaccines that are in clinical trials. Under delivery, these are vaccines that are already approved. So everyone knows that hepatitis E vaccine, hepatitis E, is approved in China and Pakistan. But it is not approved by WHO. It's not pre-qualified by WHO. There's no real SAGE recommendation. There's kind of a recommendation that you could use it if you really need it, but WHO itself does not endorse it. And this has been a problem because with all the hepatitis E outbreaks around the world, this approved vaccine cannot be used or will not be used because countries are reluctant to use something that doesn't carry that pre-qualification approval or the SAGE recommendation from WHO. So IVI is working with Innovax to develop the dossier in order for Innovax to now apply for WHO pre-qualification to make this critical vaccine available for global health and for UN agencies to purchase it. Then under epidemiology and surveillance, you see a kind of wide list of organisms that IVI is doing epidemiology and surveillance on. And I think really importantly, a number of these protocols are actually protocols that look at febrile infections. So we may not discover the pathogen, but those banked samples could be very valuable as we look to different disease pathogens in different parts of the world. How do we do it? So again, IVI believes in an end-to-end approach. We start with a need. So for instance, a safe and effective cholera vaccine. And then we secure funding from an organization like the Gates Foundation. We work with a developing country manufacturer. In this case, it was Shanta Biotechnics in India, to secure the manufacturing, to do the human clinical trials, to develop the regulatory approvals and WHO pre-qualification, creating a vaccine supply, at the same time working with the WHO and SAGE to get pre-qualification and recommendations for use, to work with Gavi to create the stockpile, to do advocacy with different organizations, to work on the Global Task Force for Cholera Control, to try to develop strategy around the use of that vaccine. So at the same time that we're developing a vaccine supply, we're working on the demand mechanism to get the vaccine use approved by different organizations around the world, including ministries of health and ministries, hopefully, of finance, which will support vaccination globally. And it's only then, after we have a supply and we have demand, that we really get to impact. And impact then, lives saved, decreased disability associated life years or DALYs, and then all the other benefits of vaccination that we don't really talk about, that we have difficulty finding numbers for, but which are the true impact. Lowering poverty, improving cognitive and physical development in children, improving educational attainment, all things that that are known to associate with vaccine, successful vaccination, and then economic growth. So what we see at the end, the impact, is actually a part of a process that starts with identifying the need and justifying work on a vaccine, securing funding, working with manufacturers for supply, with global organizations to create demand, and then finally with vaccination programs. This gives you an idea. So these are just the vaccines that IVI has worked on by itself, from IVI's laboratory. So oral cholera vaccine, of course, is the first, and you can see the pre-qualified products that are listed there. Vaccine number 2 is a typhoid conjugate vaccine. It's also pre-qualified, actually this year, and by SK Bioscience, and a version by Biopharma, the Indonesian company, has been approved locally. They're still working on the WHO pre-qualification dossier. Vaccine number 3, non-typhoidal salmonella. You can see that was an internal investment of IVI funds, now supported by the Wellcome Trust, and different manufacturers, not only SK Bioscience, but one that we can't talk about yet, are in discussions around being the definitive manufacturer for this vaccine. At the same time, IVI works significantly on training people to do vaccine research, development, manufacturing, and uptake. So these training courses include the one-week vaccinology course, the IVC International Vaccinology course, GTH, the Global Training Hub in Biomanufacturing, which has now had over 1,000 individuals actually through the course, having taken all the modules, passed all the tests, and received the certificates at the end. A number of different training initiatives, including the GHSA, but also very importantly, and actually to follow on this meeting, the AVSSR, the ASEAN Vaccine Security and Self-Reliance Program, which is done with the Ministry of Public Health and National Vaccine Institute in Thailand. And so that manufacturing training course will occur after this one, after this meeting. And then, of course, technology transfer. So IVI has done 14 technology transfers of 6 different vaccines. So not only oral cholera and typhoid conjugate vaccine, but also the dengue vaccine that Butantan recently announced, 79% vaccine efficacy, was a technology transfer with funding from the German government to transfer the US NIH dengue vaccine to Butantan. And now we've seen the efficacy results. Technology transfer is a critical part of sustainability. This gives you a better idea about the Hong Kong Jockey Club Global Health Institute. HKJC pledged an estimated $65 million over the course of 5 years to develop 5 different work streams with the 3 partner organizations, IVI, the University of Cambridge, and Hong Kong University. IVI's work streams are number 1, which is pandemic preparedness, and also that pandemic preparedness includes master's and PhD training at one of the target universities or organizations. And the second part around this is support for clinical trial sites that are conducting epidemiology research, primarily in Africa. Then the second IVI work stream is around vaccine process development, which is a critical pre-industrialization, a critical process. Oops. Okay. Yeah. A critical process to before we can do technology transfer. You can see that Cambridge is supporting immunology, Hong Kong University, a little bit of vaccine development, but also economic and health systems modeling. So IVI's impact. The first ever low-cost oral cholera vaccine, 150 million doses are shipped globally. Vaccine discovery and development, over 180 projects have been completed since 2015. Over 20 epidemiology and impact studies have been conducted since 2015. Technology transfer, 14 technology transfers of 6 different vaccines since 2005. Pre-qualification, 5 vaccine products have been pre-qualified by WHO, and this does not include 2 additional COVID products that were not IVI products, but where we significantly participated in the phase 3 trial activities that were necessary for pre-qualification. Training 1,000 people in Global Training Hub, and another 5,000 or so have been trained through the International Vaccinology course. And of course, IVI's published a significant amount since its inception in 1997. This just highlights some of the key progress that we've made in the different groups. So CARE, the Clinical Assessment, Regulatory, and Evaluation Unit, and these are just the major points. There is an additional information on what they do. They completed a RSV phase, so respiratory syncytial virus phase 3 trial in Nepal. This is actually a vaccine from Sanofi, and we're highlighting it not because it's an IVI vaccine, which it isn't, it's a Sanofi vaccine. But the trial sites in Nepal had not done clinical trials before we trained them to do GCP for a typhoid conjugate vaccine trial. Since then, they've done the typhoid conjugate vaccine trial. They've done a COVID trial for Sanofi. They did so well in that COVID vaccine trial for Sanofi. Sanofi signed them up to do the RSV phase 3 trial. This repetitive activity allows the sites in Nepal to develop capabilities and become sustainable. And that is the goal of the training and good clinical practices that we give. The ultimate goal is to have sites that countries or companies or other organizations can use in order to test vaccines for global health. Hepatitis E, again, I've mentioned this before, developing the dossier that will allow WHO to pre-qualify the vaccine and SAGE to issue a formal recommendation for its use. Cholera conjugate vaccine, I think we talk a lot about the oral cholera vaccine, but the oral cholera vaccine has a notable gap. It doesn't perform particularly well in children under 5. So working with professor and investigators at the Massachusetts General Hospital, a part of Harvard University Medical School, we're developing a cholera conjugate vaccine, actually with partial support from the Korean government as well. So as we've gotten more complex, we've had to involve more and more funders in any vaccine project. So we might have a project that has funding from 3 or 4 different organizations in order to have the total funding package that will allow us to move forward in clinical trials. This is the epidemiology unit, also known as EPIC, Epidemiology, Public Health, and Impact. They're doing a vaccine trial against schistosomiasis. We are entering phase 2A and phase 2B. The funding is still pending, but will likely be funded largely by the Bill and Melinda Gates Foundation. The preparation of West African sites in a program known as ARQUA to prepare them for phase 3 trials. The first phase 3 trial, we hope, will be the phase 3 trial of a Lassa fever vaccine, which CEPI is currently engaged in phase 2. Finally, the Hong Kong Jockey Club Global Health Institute, Florian Marks, who is the Deputy Director General in charge of EPIC, is the co-director of the GHI. The science unit, again, if you think about IVI's 260 or so employees, the science unit has 70 of those employees. And it's focused primarily in Korea. Although now with the Hong Kong Jockey Club expanding, the new laboratory in Hong Kong will be an additional number of people, including some senior investigators who can help with process development. They work on a large number of different things. They can do vaccine development, so oral cholera vaccine, typhoid conjugate vaccine, non-typhoidal salmonella vaccine. They're hoping to begin work on a vaccine against Klebsiella pneumoniae, which is a major cause of antimicrobial resistance, but also a significant neonatal pathogen in low and middle income countries. So the science unit can develop its own vaccines, but very importantly, it develops those techniques that are necessary for the vaccine's immunogenicity, the ability of the vaccine to induce an immune response, to measure that, and to do it through means that are validated. That is a test that will be acceptable to regulatory agencies around the world. And so they supported SK Bioscience's COVID-19 vaccine and did a technology transfer working together with the Ministry of Health and Welfare in Korea to let the Ministry of Health and Welfare develop its own validated clinical assay system for different vaccine trials. We've actually transferred validated clinical assays to other organizations around the world, and that will include, hopefully, and you'll see it soon, some of the work that's being done with BioVac, which is a South African company. So a number of different CEPI projects, including the CEPI Global Vaccine Library, their biospecimen sourcing, the centralized laboratory network, that application is pending, and then initiation of IVI's vaccine number 4. So remember the other 3 vaccines, vaccine number 4 may be Klebsiella pneumoniae, but that actually is still needs to be presented to our scientific advisory group. We have it's not a unit, it's a department called Innovation, Initiatives, and Enterprise Development. And again, you'll see how these different organizations work together within IVI. So the science unit is working on vaccine number 4. The investment case for vaccine number 4 is actually finalized by the business development and enterprise development people who are working in what we call I2N3, Innovation, Initiatives, and Enterprise Development. This organization, New Initiatives, actually is really important to us because IVI is contacted often by governments or companies or other organizations and asked about the development of different types of vaccines. This becomes our intake mechanism, and it becomes a way for us to log in every group that contacts us so that we don't lose track of new initiatives. So they come in, they are discussed, there are meetings held with different organizations, non-disclosure agreements signed. They do a lot of work in order to identify those projects that IVI might want to carry forward. And once that's completed, often once funding is obtained, then that project is transferred to the other units at IVI. Training and capacity strengthening, and I've told you already about GTHB and some of the work that's done in the Global Training Hub that is the Ministry of Health and Welfare and WHO funded and supported activity, but also the International Vaccinology course. But IVI's training team has also been to individual countries to do actual gap assessments and on-the-spot training for different organizations around the world. And we list this one here, although it really belongs in a different place, and you'll see where in a second. BP-CoV-2, broadly cross-protective coronavirus vaccine, is a collaboration with Dr. Drew Weissman at Penn University, with Dr. Kiat at Chulalongkorn, and with BioNet Asia. So this is a CEPI-funded, very large project to develop a vaccine that is coronavirus-proof, not COVID-proof, but one that will prevent human coronaviruses, so seasonal coronaviruses, MERS, SARS-1, and current and future coronaviruses through a very sophisticated AI program that Jesse Bloom at the University of Washington is collaborating with the group on. So very interesting, and we will locate this effort in Africa. So this is the European Regional Office. The European Regional Office does a lot of stakeholder engagement with European countries, but has also been supporting the activity, establishing the office in Africa. It actually is a funding arm of IVI. So the Swedish government provided enough funds for IVI not only to support the office itself, but to use those funds to get critical preliminary data that allow us to apply for new grants. So using the funding from ERO, different organizations have been able to secure grants from the Wellcome Trust, and actually, hopefully soon, from the FCDO, the Foreign and Commonwealth Development Office, using pledges of funding from ERO as IVI's stake, IVI's commitment to developing vaccines for global health. The final point is that ERO itself is an organization that can apply for funding within the European Union. And so they actually have have received funding from EDCTP and Horizons, and they have several other grants under review. So strategy. And we've never really talked about this before, so if you have questions, this is the time to ask about it. When I came on in 2015, IVI did a new strategy. And at that point, we were a very small organization. George can tell you more about where we were at that time. The key to that strategy was to consolidate IVI and to focus on the mission. So you can see sustainability, relevance, and capabilities, the things that were going to make IVI successful in the future. As we got to 2017 and 2018, IVI began to turn around and began to grow. And the real question was then, how do we get this growth to accelerate? So you can see on top of the original blue triangles, we added, we need new sites to work in, we need new vaccines to work on, and we need to have the people who can do the work of vaccine research, development, and manufacturing. That strategic update in 2018 became a new 5-year strategy in 2021 approved by the board. And that really was, again, building on the new sites, new vaccines, new people. How can IVI amplify its core activities in discovery, development, and delivery? How can we scale our global footprint? So IVI in November of 2021 existed only in Seoul, in the Republic of Korea. And now you can see IVI has sites in Sweden, Austria, soon in Kigali and Nairobi, opening new, and in Hong Kong, now opening sites around the world. And this international expansion was point number 2 under the strategy in 2022. And the final one is future-proofing governance. So the Global Council is the proof of future-proofing governance. We wanted to have our member states provide input to the Board of Trustees, advice and input on where IVI should go, what we should work on, how we should do things in the future as an international organization. IVI in 2021 did not have any representation on the Board of Trustees from countries that were not funding countries. And now that's been changed. Right now, Rwanda and Bangladesh represent IVI on the Board of Trustees for the countries that are member states but are non-funding. And as we look at these things, we're building on all of the previous strategies and creating additional value for the world in terms of the development of vaccines, which are necessary in order to achieve good health. So our board, not being satisfied with that, actually asked us to do an update. And what you're going to see in some of the future slides is a peek at what we are saying we will update in the next 2 years. So this is the current strategy. You can see the vision and mission as the roof of the house. The pillars that support the roof are IVI as a research institute, IVI as a product development partnership that does vaccine development, epidemiology and surveillance, and vaccine effectiveness, all built upon a foundation of IVI as an international organization. And around this organization of IVI are the strategic initiatives: amplifying the core, becoming bigger and better at discovery, development, and delivery, expanding internationally or scaling the global footprint, future-proofing governance, becoming more inclusive and responsive to our member states. Really critical aspects. And IVI really has achieved that. So in the time since the approval of the strategy in 2021, we've grown. We've gone from a single site to multiple sites. Our funding has expanded to a total of over $100 million in 2024. We've got significant number of new sites, and we've changed the governance. And the real question now is, you've grown so far, you've gone so far and grown so fast, how are you going to be able to sustain that? So this is a kind of complicated slide, but what you can see is at the bottom, amplify the core, scale the global footprint, and future-proof governance. So these are the basis. This is where we started with the strategy. At the top of the pillars of the strategy, you can see IVI's growth, a 31% annual growth rate, a footprint that now includes multiple organizations around the world, and governance that now includes non-funding countries, the Global Council, and the Global Advisory Group of Experts. So we've done all of these things. We've grown very fast. We've expanded internationally. And how are we going to sustain that? How are we going to stabilize this structure? So to do this, we have developed a series of what we call cross-cutting initiatives. These cross-cutting initiatives are designed to stabilize the pillars of growth and expansion that we've done over the last 3 years. Transformational growth, which we hope will strengthen IVI by creating, again, a sustainable way to do discovery, development, and delivery. We want to integrate IVI, which is, was easy to integrate when you're one site. Now that we're multiple sites, we have to make sure that everyone understands what the team is doing, that we all participate equally in the development of the vaccines that are moving forward for global health, and that finally we understand risk better. Because as you're expanding, as you now have formal international sites, we take on a different level of risk. Is it going to be possible to conduct business as usual? No, I don't think so. And how are we going to be able to report risk to the Board of Trustees and manage that risk as we move into very complicated situations globally? And I think that's the reason why the third transversal exists. The final section is on Africa and strengthening manufacturing in Africa. And I think you saw a presentation of this last year, so I apologize for it being slightly repetitive. In 2019, Africa manufactured less than 1% of the vaccines that it used. The Africa CDC, PHAHM, which used to be PAVM, wanted to have Africa in a position to manufacture 60% of its vaccines by 2040. There are lots of good reasons for regional vaccine security and for national vaccine security. And you can see them here: pandemic preparedness, tackling endemic diseases, improving supply security. We proposed, and last year the Global Council recommended, that the board support the Advancing Vaccine End-to-End Capabilities in Africa, or AVEC Africa, which uses IVI's ability to do work along the entire vaccine value stream, from epidemiology, surveillance, and effectiveness, all the way through to help with demand generation.
So taking all of those things that IVI can do and creating a similar set of capabilities in Africa that will train that next generation of people who will develop and deliver vaccines that will be useful to countries in Africa in support of sustainable manufacturing. So the idea was that focusing on manufacturing, and right now there's $3.5 to $5 billion pledged for African vaccine manufacturing. Focusing on manufacturing itself ignores the bigger problem. Where's the ecosystems to support sustainable manufacturing? And AVIC Africa is going to use IVI's capabilities to take individual vaccine projects and use those vaccine projects to train people in how we do laboratory analyses on vaccines that are being developed, how we do clinical trials, how we work with regulatory agencies, with WHO and other organizations to gain the demand side of the equation, how we work with procurement organizations to secure those vaccines that will then be implemented, and then finally, how we do the analysis of cost effectiveness to say that those vaccines really are doing what we say they should be doing. So this is the AVIC Africa, and we hope that through end-to-end product development, AVIC Africa will accelerate the development of a robust vaccine ecosystem, supporting the ambitious objectives of Africa CDC to produce 60% of Africa's vaccines on the continent by 2040. So it will start with R&D and clinical development. It will involve technology transfer, and you'll see some of the technology transfers that we've been doing, regulatory authorization, and this includes strengthening those regulatory agencies that are necessary to be able to inspect and verify that vaccines manufactured in Africa are suitable. Vaccine manufacturing itself, demand generation, and delivery. So moving along this entire roadmap, AVIC Africa hopes to create sustainable manufacture, or support sustainable manufacturing in Africa. So the Africa CDC, and you can see Platform for Harmonized African Health Products Manufacturing, PHAHM or FAM, used to be PAVM, Partnership for Vaccine Manufacturing, had 8 strategic elements in its framework. AVIC Africa actually supports 4 of them, and those are the programs 3 through 6. And we hope that through this cooperation with Africa CDC and FAM, IVI will be able to start to participate in significantly enhancing the ability of African countries and companies to conduct sustainable manufacturing. This is the example, and it's ongoing. So we don't have the end of it yet. But if we think about the simplified oral cholera vaccine, we did with funding from Bill and Melinda Gates, the Wellcome Trust, and actually the countries that support IVI, so Korea, Sweden, India, Finland, Thailand, and now Austria, we're able to do work to simplify the oral cholera vaccine. With funding from Gates, working with BioVac, which is a South African vaccine manufacturer, we were able to transfer the capability to manufacture the vaccine. They are now through phase 2, so they are now able to manufacture at scale. And the key questions about whether this vaccine actually now is equivalent to the vaccine that was manufactured here in Korea by U Biologics is the next set of questions. And we are currently trying to assemble the significant funding that's necessary for the clinical testing of that vaccine. We've actually secured several funders already, but we're waiting for the final piece of the funding to fall into place. You can see here that BioVac is a key partner. And I think importantly, IVI is not the recipient of the grant. The grant that funds the technology transfer goes to BioVac, and IVI receives funding from BioVac to support our activities. Increasingly, as we think about this, countries and companies in Africa have to be the recipients. They have to be successful at receiving, at securing, so writing a proposal, securing the funding, and then executing the funding according to the milestones in the grant. And IVI will support that activity to help BioVac be successful. If we are successful, this will be BioVac's first ever from scratch vaccine. They do fill and finish for a lot of vaccines, but I think everyone here realizes that fill and finish, while it's wonderful and important, is not going to supply Africa with vaccines in a pandemic, because the same issue of vaccine shortages is going to apply to fill and finish as it does as it did during the COVID-19 pandemic. So working with BioVac, using them as the funding recipient, all very important parts of a conceptual shift to making vaccine manufacturing a sustainable activity in Africa. So in order to support this, we now have an IVI regional office, which will soon be set up in Rwanda. Actually, we're getting very close. The host country agreement should soon be signed within the next 2 months. The AVIC Africa Project Office, which will be located in Kenya, has also advanced significantly. The Memorandum of Understanding should be signed, Memorandum of Understanding should be signed in November. And you can see that we have, we're actively recruiting the head of the regional office and the head of the AVIC Africa office, and both of those are quite advanced at the stage of being able to offer the positions to different individuals. So you can see, as we look at manufacturing support, vaccine development and clinical trials and training programs, different organizations have been supported under manufacturing, under vaccine development, and under training programs. The things with the stars are listed this way because these organizations are receiving the funding, and IVI is collaborating with them in order to do the work. Again, this new model of having organizations in Africa successfully apply for funding and having IVI as a partner is really a critical part of this new strategy of creating the capability to do what IVI does in the subcontinent. Thank you. Sorry, questions?
Thank you, Jerome. We now have 15 minutes for question and answer session. I would like to invite GC representatives to ask any questions you may have. If you're interested, please raise your placard and we will provide you the opportunity to speak as you wish. Yes, recognizing Pakistan.
Thank you so much, Jerome. That's really exquisite, brilliant, I must say. I mean, the growth and within such a short span, and I think the way things have worked out, even during COVID, you never stopped. So I think a big congratulations to you and to your team for making it happen on continuing basis. It's very difficult, and the momentum. Some of the key areas, talking in particular about, we've got now expanding in Africa to quite a great extent, and we practically seen those things coming up in African region. One of the areas that you did touch is the regulations, and I think talking of the GMPs and regulations within the LMICs in particular. So what additional focus would IVI pay to that? And secondly, just for my own clarity, you talk about one of the training homecoming. So how would you elaborate that? Thank you so much once again.
Thanks. I'll do the training homecoming first because it's the easier one. The 5,000 or so people who have been through different training courses at IVI have never been contacted in follow-up to find out what they're doing, if they're continuing to work in vaccines, if they've moved on in their careers in ministries or have moved to companies or to universities. So we actually have a special training activity. It's a refresher course that will go out with the request for contact. So it's kind of a reward if people write back to us and say, yes, I've been promoted in my job, or we're actively manufacturing a vaccine, or I moved on to a different university and now I'm doing work on a new pathogen. So that's the special training activity, and that's going out to everyone whose email addresses are still correct in our database. And it'll be now an annual activity because increasingly the Global Advisory Group of Experts and our board want us to measure the impact of training. It's one thing to say 5,000 people have come through the course. It's a separate question to know what these individuals are doing with the training that was provided. The second part, and I suggest that you speak to Doug Schaefer about this. Until he joined IVI, which I think was a week ago, or no, 3 weeks ago, he was the Associate Director at the U.S. Food and Drug Administration for the International expansion and to support for AMA. So Doug is one of our experts. We also have other individuals working at IVI who've worked for EMA and for Anvisa in Brazil. And we're hoping that with them as the core, we will be able to expand some of the regulatory support activities that we provide. Now, as with everything at IVI, all of this comes with a proviso that we have to find funding to support this. So some of the funding, of course, will come from the funding countries, the countries that provide funding to IVI. Other funding we actually are actively seeking. So, for instance, with the University of Rwanda, with the Karolinska and the Swedish government, we're together funding a clinical trials development capacity in Rwanda. And that activity actually, we hope, will strengthen not only the clinical trials capacity, but also some of the regulatory capacity that would go into conducting clinical trials safely. So I suggest that you speak to Doug as he thinks about how to develop this kind of activity at IVI. Others? No?
Yes, recognizing Thailand.
Thank you very much, Dr. Kim, for sharing very impressive work. And I, as Thailand, as the country benefit from joining IVI. So I think there are several activities that we can work together. I saw your slide, you show many vaccine in the development, and those are the neglected tropical diseases in many countries. For example, the cholera vaccine, RSV, hepatitis E, and adenovirus. I have a quick question about the hand, foot, mouth disease. This is common in Asia and also in other countries. So any plan for the development of the like Coxsackie vaccine and also the enterovirus vaccine?
So that's a great question. Earlier this year, actually this was the second meeting, the WHO convened a meeting around the use of the WHO mRNA manufacturing hubs. And one of the work streams in that activity is to develop an mRNA vaccine for hand, foot, and mouth disease. Now, this would be unique because you might be able to then position, because of the speed and ease of changing constructs for mRNA vaccines, you could actually make the mRNA vaccine for hand, foot, and mouth disease very country-specific. So for the countries that have the manufacturing capability in Southeast Asia, that includes Thailand, it includes Vietnam and Indonesia. So you could actually have points within the region that are manufacturing a region-specific combination vaccine. The Chinese have an inactivated vaccine already approved. They're working on mRNA vaccines, but other countries could as well. And whether those vaccines would then protect, I think, is the big question. There is a correlate, at least for one of the Chinese vaccines, which makes it a little bit easier as we're looking at potential mRNA constructs. But as with everything, and this is one of the key elements of what IVI does, we have to secure the funding in order to move forward. Vaccine development does have a cost. For IVI, it's not the $500 million to $1 billion cost that is often quoted. I mean, you saw that our vaccines, number 1 and 2, were between $28 and $29 million from end to end. Not all vaccines are that simple. I mean, Dr. Nakorn and I worked on an HIV vaccine. The US and other organizations spend $700 million a year developing a vaccine, and we still don't have one. But for other vaccines for global health, it may be possible to find pathways to more reasonable funding solutions that aren't necessarily going to be, hundreds of millions of dollars. And I think that might be something to further explore. And WHO is very interested in working on this. And Thailand, of course, is going to be important because as a part of this mRNA hub, Thailand was very active in soliciting WHO support for the mRNA development. And so I think Thailand, under this plan, will be doing an mRNA dengue vaccine, in addition to others.
Thank you very much.
Yes, recognizing Kenya.
Thank you, Jerome, for the brilliant presentation. I think you've spoken quite a bit about Africa and what the IVI is doing, the amazing job that has been initiated in Africa. Could you comment on the interactions between the IVI and the Africa CDC, for example? Because I think it's important to have a collaborative effort across the continent with other partners who are leading health initiatives. Thank you.
Thanks, Dr. Luciola. So it's been a learning experience, I think, for IVI. First, in setting up the offices in Africa, and then second, and actually with the encouragement of the Global Council, the Global Advisor Group of Experts at last year's meeting, some advice on how to proceed in discussions with Africa CDC. So we now have, it's supposed to be every 2 weeks, but it's now been more rather monthly meetings with the PHAHM to update them on what we're doing. As Mpox has been emerging, actually there have been discussions with PHAHM around a potentially new set of Mpox vaccines that may be tech transferable into Africa. There have been increasing, so IVI has now agreed to provide 2 secondees to Africa CDC through the epidemiology and surveillance programs. This is brand new. So still somewhat under discussion, but as we integrate and want to support Africa CDC, it's clear that the capabilities and interest are there, but there's just a shortage of people. So to the extent that that governments in Africa under the African Union or other funders can provide support to put key personnel into place at Africa CDC to make it a more effective partner for things that move fairly quickly. I think development activities sometimes take a long time to get started, but once they start, in order to keep to timelines, we have to move things along. And so it's going to be important for organizations like Africa CDC to have personnel in place who are able to work cooperatively with the different partner organizations. And I think that's one of the key next steps for us, is finding that additional funding to put people into place to make Africa CDC a much more effective partner as we move quickly through development programs. Great question.
Welcome to session 2 of the 2024 IVI Global Council. I hope you all had a refreshing and relaxing lunch together and got to know each other a little bit better. As we begin session 2, we're going to go around the table and hear the remarks from our Global Council representatives. Starting today, we'll be hearing from Dr. Mohammed Shabir Ahmed Osmani, representing Bangladesh.
Thank you, Mr. Colin. Honorable representatives from IVI member states, Your Excellency and distinguished guests, it is my honor and pleasure to meet with all of you in this prestigious meeting in lovely city, Thailand. I would like to Dr. Opart, Minister of Public Health, Kings of Thailand, role in hosting and leading Global Council in this year. Distinguished guests, based on the recent experience of COVID-19 pandemic, we have selected 5 priorities of national vaccine strategies and capabilities in Bangladesh. We can going to discuss briefly. I have only 5 minutes times. So I discuss very briefly. The first priority is a competent vaccine producer to support local and global needs. Currently, Bangladesh, the need is satisfied through the limited manufacturers like Incepta and other pharmaceuticals limiteds, and also limited import by some entities like Janata Traders and also some other enterprises. But become a competent vaccine, government of Bangladesh emphasizes 3 factors. One is government initiatives. Second one is regulatory authority,
and private industry. You know, the government of Bangladesh state-owned essential drugs company limited vaccine manufacturing facility is under the construction, which will act CMO for local and international communities. The Bangladesh government also established a biotech and research center to achieve the capacity to carry out the fill and finish imported antigen. The government of Bangladesh emphasized our regulatory authority, that is DGDA, which now in position is level 1, but we are trying to maturity level 3. That's as a result, we can achieve the qualified vaccine shall be released. And Bangladesh government also emphasized the some private industries which are going to produce the vaccine. Some global, some example is Globe Biotech, Incepta Vaccine, Popular Pharma, and Healthcare Pharmaceuticals Limited. Number 2 priority is to assure the sustainable development of suitable vaccine technology to acquire pre-preparation for future threats. You know, the research and develop is very essential. No RD means unprepared future, we know better. So developing more suitable vaccine technology for easy storage, distribution, and administration, and identify the needs for future threats in form of new modalities for previously reported infectious agents and new infectious agents. So the government of Bangladesh emphasizes again 3 factors RCP. So I told earlier the state-of-the-art vaccine research development center for EDCL is under construction. And also we can emphasize the private companies, as for example, Globe Biotech has established integrated research facility for vaccine and biologic development. They have containment animal like mice, rabbit, and monkey research lab. And also developed mRNA vaccine against the SARS-CoV-2 that got approval for the human trial from the government side. Another one of the important, the Bangladesh is Bangabandhu Sheikh Mujib Medical University and ICDRB. They have regularly executing the clinical research on the vaccine and drugs. And IDSA is another institution which is also doing clinical research for epidemiological aspects of the infectious disease. So we need to process technology. The Bangladesh has been working with WHO to receive a relevant modern technology for manufacturing of vaccines, and also some private sector like Globe Biotech also has developed cost-effective original manufacturing technology for mRNA vaccine and relevant nanotechnology, and successfully transferred the technologies in production line. So a tripartite association between government, industry, and academia under the development of enhancing efficiency of research development program on vaccine. So number 3rd priority is the wide effective social interactivity program for infectious disease and vaccine. Currently, occasionally campaigns executed as and when required, but posing a big risk for acquiring new infectious agents from nature, uncontrolled quick spread of clinical condition, and effectiveness of vaccination program. So the government of Bangladesh emphasizes 3 factors. EAT. We know this successful program, we need 3 things: educating the peoples, awareness of the peoples, and as a whole as the trigger action. So recent COVID-19 management and also our routine EPI program, Bangladesh has tremendous successful history due to this awareness of the peoples, educating the peoples, and all our work together both multisectorial coordination and cooperation. That's why, and also we have a wide network, well-established network all over the country. That's why we can manage the COVID-19 vaccination and COVID-19 management and vaccination program, as well as our routine EPI program. So Bangladesh has a good, successful history. So education, awareness and trigger, these are the most important for successful any program. So another priority is development of adequate quarantine and relevant priority management system. Currently, we have a limited quarantine facilities, those who are established during COVID-19. But of course, there is posing a big risk when uncontrolled quick spread of the clinical condition and effectiveness of vaccine program due to social mix-ups. So we need to adequate quarantine and relevant management system that should be permanent, adaptable and convertible. And so the last priorities of national vaccination and capabilities, developed a dynamic and scalable logistics system for assuring quality vaccine on time at any place. Opart logistics system for low temperature of 4 degrees Celsius vaccine is available, but very limited ultra low temperature -20 to 80 degrees Celsius logistic facilities are available, which are developed mainly during the COVID-19 pandemic. But still there is a possible big threats for our country. Storage and distribution of mRNA or alike vaccine, which are temperature sensitive, we know. And such vaccines cannot be made available to most of the needful population. So we must develop a dynamic and scalable logistics systems for assuring quality vaccine on time at any place. So if we produce quality quality vaccine that is by proper temperature or proper safety and efficacy, since mRNA and alike technology vaccines are showing better safety and efficiency, establishing relevant logistics is now not an open option, but must at least for the next decades. So if we mRNA virus, you see that just green manufacture from the distribution, then storage, then administration. Ultimate result, the product quality will be continuously degraded. So we have to emphasize on this field. So my humble request, recommendation to the IVI, we should develop, build and nurture. So suitable vaccine using mRNA or alike technology resulting superior vaccine, but with the objectives of stability at 4 degrees Celsius, if not at room temperature. So build a center in Bangladesh, considering socio-economic condition, and also parallelly we need educated manpower, infrastructure, and also there's a big population in our country. So nurture, create a research fund for industry, academia, collaboration for developing country like Bangladesh, and promote collaboration with local industry to harness the innovation. So finally, the Bangladesh firmly believe that IB will continue to thrive as a leading vaccine center in the coming years and contribute to the global public health, vaccine research and development. Thank you very much. Thank you for patient sharing. Thank you so much.
Thank you, Dr. Shabir. At this time, we will turn to pre-recorded remarks by Mr. Leandro Pinheiro Saftale from Brazil.
Dear Dr. Jeremy Kim, Director General of the IVI, dear Dr. Opart Karnkawinpong, President of the IVI Global Council, distinguished Global Council members, ladies and gentlemen, I am honored to be in the position of nominated representative for Brazil in this outstanding group, the IVI Global Council. And though I could not be present in the occasion, unfortunately, I could not miss the opportunity to leave a message of enthusiasm and respect for the work carried out within the IVI. Under President Lula's administration, the health economic industrial complex represents a new standard of sustainable development driven by challenges and oriented towards the mission of building a resilient health system, expanding access to health, increasing national production of vaccines, medical devices, and medicines. The federal government, under the leadership of the Minister of Health, has been working intensely to promote industrial environment favorable to investment in research, production, and innovation in health. For this, Brazil has established the national strategy for the development of the health economic industrial complex. This policy guides public and private investments in production, innovation, and research for technological solutions to face challenges in health. The vaccination deployment in Brazil is well recognized as one of the most impactful programs in the world, and we have committed to further strengthen and enhance our capability and potential beyond. So, Brazil is keen to collaborate and articulate in its expertise in technology transfer with the IVI Global Council's members. The development of vaccines platforms has origin in our well-consolidated national immunization programs that currently provides free immunobiologicals free of charge to the Brazilian population. Then, Brazil welcomes the opportunity to discuss how we could potentially collaborate in advancing R&D programs that could be highly impactful for all of us. This year, Brazil, under its presidency, has also proposed for the G20 Health Working Group to establish the creation of an alliance for regional production and innovation. This initiative aims to establish a network that brings together key actors, including countries, academia, private sectors, and international organizations for research and development and production of vaccines, medicines, diagnostics, and strategic supplies to tackle disease with strong social determinants and that may affect neglected populations. Ensuring access to safe, effective, and affordable medicines, vaccines, diagnostics, and other health products. It's a component of the full realization of the right to health, and it's instrumental for achieving universal health coverage. It is also essential for reducing health inequalities and improving health outcomes, especially in developing countries which face high prices, limited negotiations power, shortages, limited infrastructure, and patient protections. That is why we address the importance to cooperate and strengthen IVI's goals in order to promote production, innovation, and vaccine equity and access to this in this discussion council. For this reason, Brazil supports the IVI strategy to become observer in the World Health Assembly and United Nations General Assembly. Brazil looks forward to deepen the collaboration with IVI and working with the distinguished council members. Thank you very much.
Thank you, Mr. Pinheiro. Now I'd like to call on Ecuador's representative, Dr. Yimi Daniel Martin Delgado.
Dr. Opart, IVI Global Council President and Permanent Secretary and Ministry of Public Health of the Kingdom of Thailand. Dr. Kim, IVI Director General, distinguished representatives and members of the IVI Council, esteemed colleagues, honorable chair members, and ladies and gentlemen. It is a privilege to represent Ecuador today at the IVI Global Council on behalf of our national government and the Ministry of Public Health of Ecuador. Ecuador has a proud history of commitment to public health, particularly in ensuring high vaccine coverage for its population. Our national immunization programs, which started nearly 50 years ago, and high-quality vaccination campaigns have proven successful. Just for example, vaccinating 91% of children up to the age of 12 against polio, measles, and rubella. We understand the value of vaccines in saving lives and preventing diseases, and Ecuador remains a strong advocate for equal access to vaccines across low and middle-income countries and regions. But we must work forward to ensure that countries in low and middle-income regions have affordable and timely access to vaccines. And the global COVID-19 pandemic exposed the disparities in vaccine distribution, with wealthier nations acquiring vaccines rapidly while many lower-income regions face delays. And we cannot let history repeat itself. Vaccine equity is not just a matter of fairness, but a prerequisite for global health security. And Ecuador advocates for a more equitable system in which vaccines are not a privilege, but a right for all. We support IVI's ongoing work in fostering global solidarity and ensuring that vaccines reach the most vulnerable populations, regardless of geographic or economic barriers. Our national success in immunization would not have been possible without strong international cooperation, technical assistance, and capacity building efforts. Today, I want to emphasize Ecuador's support for the initiatives discussed at this council, particularly in technology transfer, equal vaccine access, swift distribution to underserved regions, and regional capacity buildings. I want to make a special focus on the regional capacity building, understanding that we need these learnings and these efforts that are being made in other regions of the world to also start replicating in other contexts, like, for example, Latin America. We must embrace new technologies to enhance vaccine efficacy, safety, and accessibility. However, adopting these new technologies requires technical assistance for many lower and middle-income countries, including Ecuador. We call on IVI and its partners to continue supporting countries in adapting new technologies such as mRNA platforms, and helping us build the technological expertise that we require to implement these innovations locally. It is important to implement these innovations locally. Ecuador is committed to building local and regional vaccine production and distribution capacity. We believe that self-reliance in vaccine manufacturing is essential for long-term health security. And Ecuador looks forward to collaborate with IVI, other member states of this global council, and key stakeholders, public or private, to strengthen our regional capabilities in vaccine research, development, and production. Ecuador stands ready to work alongside our global partners to achieve these shared goals. Let us continue to advocate for equitable vaccine access, embrace new technologies, and build the local capacity needed to protect the health of all our people. Thank you.
Thank you, Dr. Martin. At this time, I would like to invite Ms. Mira Srivastava to deliver her remarks on behalf of India.
Good afternoon to all of you, and it's been an absolute privilege to be a part of this discussion, hearing from all of you. Now, as far as India is concerned, we have a very robust immunization program in the country, where we are roughly touching around 93.4% of the population with a strong surveillance system and indigenous production of vaccines as well. From the discussions that I have gathered over in the morning hour, vaccination is a collaborative effort, and it does require a deep dive into a lot of ancillary aspects as well. And since infection and infectious diseases are prevalent, and they are going and increasing in number in both the diversity as well as the scale as well. So as my fellow colleague was telling and was mentioning in the morning, that it is a very strong supportive mechanisms to for public health, which also aligns itself with the infrastructure, the water issues, and therefore the preventive part becomes a critical point in ensuring health for all. And as Jimmy was also mentioning, that that the equity and the importance of ensuring vaccines for all becomes another driver, so that it is not a privilege of the few. So while as we understand the importance of vaccination and take steady steps towards ensuring coverage for all, this kind of collaboration, I think, will go a long way. And I am grateful to Ivy for having me invited here, and I am looking forward to hearing from all of you a little more and understanding, gain a wider perspectives on the same. Thank you so much.
Thank you, Ms. Srivastava. Next, I'd like to call on the representative of Kenya, Dr. Michael Luciola, to deliver his remarks.
Thank you. The remarks are going to focus on the thematic area of national policies that the Kenya government has put in place to support the development of vaccine research, development, and manufacturing capabilities. As we all know, immunization is one of the most cost-effective public health interventions whose impact in reducing mortality and morbidity from disease is only second to the provision of clean water. In that regard, the government of Kenya established the Kenya Expanded Program on Immunization in 1980 with the aim of providing immunization against 6 killer diseases of childhood. These are tuberculosis, diphtheria, pertussis, tetanus, measles, and polio. Access to vaccination is a key element in the progress towards universal health coverage. The decision by the government of Kenya to establish local vaccine manufacturing has been timely. In addition to being a step towards self-sustainability in the supply of medical commodities, it's envisioned that the local manufacturing of human vaccines will support public healthcare programs, national and regional economic growth, and national health commodity security, as well as enhance the capacity to control disease outbreaks which may arise in the future. Drawing from the lessons of the COVID-19 pandemic on the importance of self-reliance in vaccine supply, the government of Kenya established the Kenya Biovax Institute, whose mandate is to manufacture human vaccines and other specialized health products and commodities. In addition, the recognition of the need for technology transfer and workforce development in biomanufacturing has led to the engagement with strategic global partners, including the International Vaccines Institute. In developing the partnership with the IVI, Kenya is focusing on promoting development and delivery of human vaccines and facilitate knowledge transfer for low and middle income countries, and therefore help advance global health. Support for this partnership between the government of Kenya and the IVI has been clearly demonstrated by His Excellency the President of the Republic of Kenya, Dr. William Ruto, in the following ways. 1, progressing the Kenya parliamentary process leading to accession of Kenya as a member state of the IVI, and thereafter personally attending the accession ceremony in South Korea. It's important to note here that that this was the first time that a head of state attended an accession ceremony in Seoul, in South Korea. So it was quite a milestone. 2, hosting various heads of state at a special event during the Africa Union Heads of State Summit in Addis Ababa, Ethiopia, where the president of Kenya was appointed as the Africa Union champion for local manufacturing. This special breakfast event was co-hosted by the government of Kenya, the International Vaccines Institute, and the Africa CDC. Kenya has been identified by the IVI to be the host country for the Africa Vaccines End-to-End Capability Initiative, the AVEC project for Africa. Kenya's Ministry of Health, working with the IVI, have jointly agreed to support the development, manufacturing, and delivery of human vaccines at the BioVax Institute for Kenya and other countries in the region. The government is also facilitating joint research in vaccines and biopharmaceuticals between universities and laboratories in Kenya, working closely with the IVI. In addition, the government of Kenya is providing training and education opportunities for global vaccine workforce development to enhance vaccine production capacity in low middle-income countries. Therefore, as a new member state of the IVI, Kenya expects to benefit from technical hands-on training to develop skill sets across vaccine development and production processes, including biomanufacturing, biosafety, and good manufacturing practices. Kenya also expects to enhance its global health recognition and also information exchange with the IVI and partners on vaccines and potential collaborative opportunities. Participation in IVI diplomatic events would also help to elevate Kenya with this partnership. Assistance with global health programs, vaccine development, technology transfer of vaccines to local manufacturers is also a benefit expected from this partnership. Indeed, the IVI has already commenced collaborative activities in Kenya, including developing local manufacturing capability at BioVax, working closely with other international partners, establishing the Africa Vaccines End-to-End Capability Office in Nairobi to focus on epidemiology, research and development, technology transfer, regulatory approvals, manufacturing, and delivery, including market shaping, access, and equitable distribution. To develop the local workforce in biomanufacturing, starting with on-site training at the Kenya Medical Research Institute and working closely with the universities and other local biomedical institutions. In conclusion, the government of Kenya notes that the collaboration with the IVI to establish capacity for local manufacturing of vaccines within the country will, as a key economic pillar, allay the current challenges encountered in the importation of over 70% of the country's medical products. This will also be a positive step in the country's attainment of the development objective of universal health coverage, as enshrined in Kenya's administration manifesto and the constitution. Kenya's membership to the IVI will therefore be valuable in the efforts towards building the necessary technical capacity in this endeavor. Kenya supports the IVI's efforts to join the United Nations General Assembly and the WHO as an observer. Thank you for your attention.
Thank you, Dr. Luciola. At this time, I would like to invite the representative of Pakistan, Mr. Rahim Shah, to deliver his remarks.
Excellency, distinguished delegates and esteemed colleagues, primarily we would like to extend deepest gratitude to IVI and the government of Thailand for making it possible for the delegates to attend this very important and prestigious occasion. Myself and Mr. Rahim are deeply honored to represent our country The world has witnessed the profound impact of vaccines in saving lives. However, the recent global crises have underscored the critical need for a stronger international cooperation and a more resilient vaccine research and manufacturing system. I think COVID has truly highlighted, and for years and years we have been talking of any eventuality, and that came in the form of a coronavirus. And I think this is the best time in the post-COVID time that we gather our thoughts, we gain the momentum, we are talking of pandemic treaty, we are talking of pandemic fund. So I think this may be the best time for talking in particular the most important preventive aspect that remain vaccine. Today, we would like to address key issues concerning Pakistan national vaccine R&D manufacturing. Pakistan is committed to strengthening the vaccine research, development, and manufacturing capabilities. The government has taken several steps to create an enabling environment for vaccine production, including encouragement of public-private partnership, the development of local manufacturing, and increased investment in research and innovation. And I think this private sector has come up very well during COVID, and that's a great learning coming out of it. And that needs to be nurtured for almost most of the aspect, talking in particular of universal health coverage, as we just heard from our esteemed colleague. The National Institute of Health in Pakistan plays a very pivotal role in this regard, supporting both local and international collaboration to boost vaccine research and development. We are focused on fostering indigenous manufacturing capacity with goals of not only meeting the domestic needs, but also contributing to the regional capacity building. However, this journey is not without challenges. We are fortunate to get selected for the messenger RNA technology transfer for the hub and spoke model. And definitely we remain grateful to WHO for that as well, for all the help that is being extended. And we would definitely make sure that our country gets success out of this one. And definitely, as highlighted this morning, one of the key areas, I mean, once the COVID is over, we can have a targeted approach for the messenger RNA technology based upon the regional needs. We see several gaps, particularly in technology know-how, financing and skilled human resource, and we are diligently working to address these gaps. As far as the response to monkeypox is concerned, Pakistan has swiftly implemented public health measures focusing on early detection, isolation, and treatment. Our border health agencies are fully active in this regard, and there's a mandatory screening system at the airport. Our health services have been vital in tracking the spread, while public awareness campaigns have been deployed. However, the monkeypox outbreak also highlights the global issue unequal access to vaccines, and Pakistan believes that the global emergencies require global solutions. So we just again heard about the equity, that's something again very, very important. We truly believe in greater information sharing and strengthening the partnerships with international organizations like IVI and others, and establish regional manufacturing hubs focusing again on the regional demands. As far as the strategic priorities for the IVI 2027 to 2031 plan are concerned, we will try to play our critical role and in guiding global vaccine development efforts. We urge IVI to align its priorities with the national policy and regional needs for developing countries. In this regard, we propose certain suggestions like focus on the pandemic preparedness, should prioritize research on vaccine for emerging pathogens and zoonotic, especially those with pandemic potential, and enhancing the R&D for the next generation vaccine. Support for the local manufacturing, which is definitely already going on in a very methodical manner, and strengthening international partnerships. And here I would like to highlight now, I mean, got multiple bodies like Gavi, like Partnership for the International Vaccine Initiative called PAVI, the SAPI, IVI, and then in particular allied institutes which are more toward the targeted research like SEBIN. So I think there has to be a platform having an intra-coordination of the stakeholders in order to clearly and truly understand the demand, requirement at the international and the regional level, and coordinating effort without duplication of efforts. And so that will save a lot of energy. And consider some vaccine stockpiling mechanism. I think Gavi is now as we know, is truly into it. So some stockpiling mechanism at the regional level, IVI can really think truly about that in a much more robust way with all the strengths that they have. In conclusion, Pakistan is fully committed to working with IVI and international community to strengthen vaccine R&D and manufacturing, enhance global cooperation in response to public health emergencies, and ensure the world is better prepared for future challenges. By embracing innovation, fostering partnerships, and ensuring equitable health access, we can create a healthier and a more resilient Bangladesh. So let's work out together to have a much safer and a healthier world. Thank you so much.
Thank you, Doctor. At this time, we'll turn online to hear from the representative of Rwanda joining us live, Mr. Hassan Sibomana. Are you there?
So Rwanda vaccination program actually was established in 1980, as so many other vaccination programs in Africa. And as of today, actually, we are offering 13 antigens for routine vaccination. And today, we are very happy that actually we have a very good vaccination coverage, where actually Rwandan children, 96% of them are fully vaccinated. And I have to say that actually last week, you know, so many countries here in Africa.
Mr. Sibomana, I believe we've lost the connection, but we'll stand by to see if it clears up. Ladies and gentlemen, my apologies for this technical issue. We can come back to Mr. Sibomana if we reestablish a connection. At this time, I would like to invite the... Oh, can you hear us? Mr. Sibomana? Okay. Okay. So given the technical difficulties, we're going to invite Dr. Yu-Kyung Lee, the representative of the Republic of Korea, to deliver her remarks and presentation.
Can I have my presentation slide? The screen? Okay, thank you. Dr. Jerome Kim, Dr. Opart Karnkawinpong, Chairperson George Bickerstaff, Gage Chair Anderson Durden-Strom, representatives, distinguished guests. It's my pleasure to have an opportunity to present Korea's R&D strategies to address emerging infectious disease. Since we are getting a little short on time, I will make it quick to keep to my time limits. My talk consists of a brief introduction of KDCA, how countries plan and get ready to respond to emerging infectious disease, R&D tasks for national pandemic prevention, preparedness, and response plan. In September 2020, the Korea Center for Disease Control and Prevention was upgraded to the Korean Disease Control and Prevention Agency. At the same time, the National Institute of Infectious Disease was established with 3 centers and 12 divisions under the National Institute of Health, an intramural institute of KDCA. I'm working as a director of Vaccine Development Division, one of the 12 divisions. As the disease prevention agency, we have a mandate for infectious disease and pandemics. However, we also work on non-communicable disease and health threat, facilitate R&D to scale up biohealth and medical research. What is noteworthy here is the establishment of Global Health Security Coordination Office last December. The office is playing a role in leading the global health network by strengthening international cooperation and partnership. KDCA is also working with the WHO, IVI, FIND, CEPI, Right Foundation, and so on. Korea's response to COVID-19 among many is known for the 4T: testing, tracing, treating, and transparency. During COVID pandemic, we also implemented policies to protect the high-risk populations, technical capacity for R&D, mission-oriented research, cohort on the long COVID syndrome, capacity building for epidemic investigation support system, and next-generation sequencing are what we have done during COVID. In particular, Korea's R&D support resulted in antibody therapeutics developed by Celltrion in 2021 and SK Biosciences COVID-19 vaccine developed in collaboration with the University of Washington and GSK. This vaccine was approved by MFDS in 2022. Furthermore, we are integrated infectious disease surveillance and predicted COVID-19 transmission route. I think you are already well aware of these virus families. These are all the families that international organizations such like the WHO, CEPI, and US and IAID are targeting in common. However, we don't really know what is next one and where it is coming. In May 2023, KDCA announced its National Pandemic Preparedness and Response Plan with the vision of establishing an agile, collaborative, resilient system for pandemics. It comprised 3 goals. The first is to secure essential medical countermeasures, including vaccines and therapeutics, in 100 or 200 days of the next pandemic. The second is to build resilient capacity for sustainable pandemic management. The third is to prioritize health and safety of vulnerable populations to minimize health inequalities. The National Pandemic Preparedness and Response Plan has 5 areas: surveillance and prevention, preparedness and response, infrastructure, resolution, and research and development. For research and development, we will reform our R&D support system to expedite development of vaccines and therapeutics and diagnostics, refining our legal framework with MFDS, is essentially needed. We will delve into research and development. Number one, preparedness. During the inter-pandemic period, we will secure a rapid development system based on priority pathogen here. In the case of vaccines in particular, we will establish a vaccine library and secure platforms such like mRNA, which has become our national target necessity. Number two, response. When a pandemic occurs, we plan to develop vaccines and therapeutics within 100 or 200 days, which we think it requires multi-sectional and institutional cooperation. For the response work, we are taking a two-track approach. If our prototype vaccines prepared through phase 1 and 2 clinical trials happen to target the same pandemic pathogen going forward, we will be on track 1, the 100 days mission. However, if our prototype vaccine happen to target pathogen, not the same pandemic pathogen, we will be on track 2, aiming to develop vaccine and therapeutics within 200 days. MFDS's review period, however, is not included in the aforementioned number of days. Moving on to the number 3, mission-oriented R&D, which is one of the items in the National Pandemic Preparedness and Response Plan. We will be establishing mission-based R&D roadmap protocol with the defined role of research institutes, academia, industries, expanding mission-oriented R&D. Building a performance monitoring and sharing system based on the National Infectious Disease Roadmap and scale up the operation of KDC's R&D program in line with the Ministries of Health ARPA-H project will follow. The fourth point concerns international collaboration and partnerships. We are participating in various research partnerships such as STRIVE and REPORT run by USAID, and we are keen to expand our presence in additional networks. Moreover, we plan to increase our contribution to global ODA for LMICs. I believe some of you may already be aware of our partnerships with international organizations such like CEPI and IVI. We look forward to collaborating with more entities. Additionally, this point involves the coordination of research institutes. As previously mentioned, we opened the Global Health Security Coordination Office last December. Global Council Secretariat will discuss the Mpox emergence later today. So KDCA is developing a third-generation live attenuated smallpox vaccine in collaboration with the INON. This vaccine completed GLP toxicity studies last year, and this year we finished the protection assay in monkey model. Results show that the third-generation vaccine is safer and more effective than the second-generation one. We aim to complete the development of a third-generation Mpox vaccine through clinical studies. I will conclude my presentation with a few remarks for IVI. Since its establishment in 1997, IVI has grown significantly, collaborating with many countries, industries, and academia. On the occasion of first in-person Global Council meeting, I hope the IVI contribute to expand its partnership with the more countries in the future. Furthermore, IVI's recent expansion is particularly significant as it includes the opening of regional offices in Africa and so on. I assume that Such expansion in Africa will require more cooperation opportunities to realize the IVI's vision and mission. To this end, I expect the IVI to collaborate with more capable Korean pharmaceutical companies, which will help it reach new heights in Africa. Lastly, as a member of the international community, I hope that IVI continue to help countries prepare for the next pandemic, as always. This is the end of my presentation, and thank you so much for your attention.
Thank you, Dr. Lee. At this time, we're going to return online to reconnect with the representative of Rwanda, Mr. Sibomana. Mr. Sibomana, can you hear us?
So I was saying that actually support local manufacturers of vaccines. And as you know, we have been collaborating with BioNTech to initiate actually the manufacturing of vaccine here in Rwanda. So now the manufacturing plant constructions works are under almost done, being completed. And then to support actually even the local manufacturing in collaboration with University of Rwanda, with so many partners, Ministry of Health, Government of Rwanda is supporting also the new programs. Now, biotechnology program has been initiated in the University of Rwanda, and it was actually the addition to the supply chain management course, which being offered by the University of Rwanda, because in Rwanda we are hosting a regional center of excellence on supply chain management of vaccine and other health commodities. And then actually there is also a good plan to initiate actually the vaccinology course at master's level, which will start very soon. So, and then at a regulatory level, Rwanda FDA, which is still new, so is continuing actually to be strengthened. So now if you look at the number of staff actually in Rwanda FDA, now they're exceeding 150 to support also the regulatory level. So they have been assessed like 2 times. So we are waiting actually the final assessment from WHO so that we can see what will be the conclusion on the maturity level of Rwanda FDA. At the program side, we have a very good vaccination program, which was established in 1980. So with very few antigens at that moment. At the beginning, there was only 6 antigens, but currently our vaccination program is offering 13 antigens in routine vaccination, and good enough actually if you look at vaccination coverage in Rwanda. So the vaccination coverage is always very high. So now 96% of Rwandan children are fully vaccinated, and with actually a very good experience of conducting different vaccination campaigns. So we have been able to manage very well actually the response related to COVID. And currently we are starting also vaccinating actually our people to protect them actually against the mpox. So we started last week with very few doses, and we think that actually are going to continue to receive doses. We're expecting some doses from Africa CDC, but also from other international organizations. So meaning that actually for us, we are able to contain this pandemic, because actually we don't even have so many cases. Actually, we think that with very few doses we can receive, so we can always use efficiently doses. So, and then as I conclude, I would like to say that actually Rwanda is very committed to collaborate with IVI. And also we have to say that we commend the effort of IVI to support countries and most specifically the government of Rwanda. Thank you.
Thank you, Mr. Sibomana. Continuing online in an alphabetical order, next we'll hear from the representative of Spain, Mr. Daniel Ruiz. Daniel, can you hear us?
Can you hear me?
Yes, we can hear you. Please go ahead.
Okay, that's fine. So, distinguished General Director Jerome Kim, Also, Ministry of Health of Thailand, thanks for hosting members of IVI Council, authorities, officials, representatives of state parties and observers. Ladies and gentlemen, friends, thank you very much. First of all, I would like to thank you very much for organizing the annual IVI Global Council in Bangkok. It's a real honor for me to be here, at least online, on behalf of the Kingdom of Spain, and apologize for not being there physically. For our country, IVI represents an essential instrument to discover, develop, and deliver safe, effective, and affordable vaccines for global public health. As you already know, Spain is fully committed in the needs of reindustrializing the EU and guaranteeing its open strategic autonomy. In order to achieve these objectives, research becomes essential. In this light, the COVID-19 pandemic has demonstrated that the next stage of health protection and promotion must be based on a qualitative transformation of the health sector closely tied to science and innovation. To ensure this transformation, it will be necessary to foster the transfer of academic R&D to the industrial sector through public and private collaboration tools, and the promotion of industrial capacities through innovation and industrial and manufacturing processes, in which vaccines also have a relevant seat. In that sense, we could mention the importance of funding R&D projects in vaccines, as we did here in Spain in 2020 for COVID-19 and in the previous year. Apart from that, our country is well prepared for the development of clinical trials due to an extensive funding mechanism already implemented around the country, such as boosting our clinical research units and clinical trial platforms. And we encourage to align the instruments and tools that we have also at the global level in order to be more effective. Additionally, Spain has a scientific research infrastructure prepared for the preclinical studies and ultra-fast performance research and clinical trials, including the high biological security infrastructures. A well-coordinated global commitment and support in promoting vaccines, local and regional production and innovation is crucial to combat inequalities and reducing disparities in access to vaccines, especially for vulnerable populations. Our efforts to strengthen R&D capacity, as well as quality and sustainable local and regional production of vaccines, should particularly focus on combating neglected disease, leveraging lessons learned and avoiding initiatives overlapping, as already mentioned some of colleagues I overhear. Fostering these 16 initiatives and regional excellence centers and or existing now how should be considered. These efforts must also be accompanied with structural public policies and regulatory convergence, enable local and regional productions to be quality assured and sustainable, as well as integrating into overall health system strengthening, allowing for proper development and deployment of vaccination strategies. Besides, from the recent health global crisis, we have learned the importance of cooperation between different countries, international organizations, and public companies. For that purpose, we consider IVI could play an essential role in the rapid development of effective vaccines against emergency pathogens. It includes research and vaccines development both before and during a pandemic, involving the identification of potential threats, accelerating testing and approval processes, and the large-scale production of safe and effective vaccines. We have already known about the launch at European level, a call for proposal in order to create a European hub for vaccines development that is still under evaluation. These actions aims to create a European hub for public health relevant vaccines development, combining excellence in vaccine development with clinical trials and activities for scaling manufacturing. This called targets consortium of developers of vaccines covering expertise in development, including publicly funded and industrial organizations. This information could also align the strategy of IVI in order to combine efforts in order to not overlap actions. So we encourage to IVI to contact the new European Hub for Vaccine Development. Regarding Mpox, we can say that in Spain, we have the necessary technology to carry out the surveillance of the different lineages and clades, and also massive sequencing. The surveillance protocol has been modified to adapt into the current situation. Furthermore, in general, it is recommended at the national and regional level to promote research and surveillance, and also worldwide. Regarding vaccination against Mpox, Spain has not significantly modified its strategy on vaccination recommendations for the moment. Finally, from our country, we will continue in the process of promoting and alignment, the research and surveillance, and we will also contribute to strengthen the vaccines development and pandemic management capacities of other countries through training programs, technology transfer, and scientific collaboration, playing a significant role in global coordination with the IVI and stakeholders. To sum up and some key strong ideas, we can shortlist some points. Funding, provide adequate financial resources for IVI to conduct research and build pandemic response capability. International collaboration at the second step, foster collaboration with other research institutes, international organizations, and governments to share information and resources in real time during health crisis. 3, establishment of vaccine research. 4, ongoing training. And 5, infrastructure development in Africa. In conclusion, by working together, we will be able to overcome current and future challenges. By strengthening collaboration and facilitating regional vaccine production, we can enhance the quality of research and development and ultimately improve the health and lives of everyone. Thank you very much. I'm sorry because sometimes I overhear noise on over there. So thank you very much.
Thank you, Mr. Ruiz. Now I'd like to invite the representative of Sri Lanka, Dr. Thushani Marie Elizabeth Debrera, to deliver remarks.
Thank you. Good afternoon, Chair Dr. Opart and distinguished delegates. It's a pleasure to be in this beautiful country and among this distinguished gathering and representing Sri Lanka. Sri Lanka has enjoyed a long-standing partnership with the International Vaccine Institute since signing the IVI Establishment Agreement in 1997. As a nation that previously procured its own vaccines before the pandemic and the economic crisis, Sri Lanka greatly values IVI's efforts to promote equitable and timely access to vaccines at affordable prices. During Sri Lanka's economic crisis in 2022, procuring vaccines for the National Immunization Program became challenging, and the support from the partner organizations was greatly appreciated. I'm proud to say that Sri Lanka continues to maintain a 99% coverage for infant immunizations throughout these years. Low and middle income countries continue to face challenges in securing vaccines for outbreak management. Although Sri Lanka successfully eliminated measles in 2019, it now struggles to maintain this status following a recent outbreak with an incident rate exceeding 32 per million population. While the government's response has reduced the cases, obtaining vaccines for managing the outbreak proved difficult. The potential supportive role IVI could play in supplying vaccines to LMICs during emergencies or outbreaks is worth exploring. Sri Lanka also acknowledged IVI's vital role in combating communicable diseases, particularly its focus on leptospirosis. Sri Lanka is advancing efforts to have leptospirosis classified as a neglected tropical disease by the WHO. As a member state, Sri Lanka is getting the IVI support in this endeavor to present the case at relevant forums. Leptospirosis poses a serious global health threat, causing significant illness and death across nearly 150 countries. Unfortunately, its lack of prioritization on the global health agenda has slowed progress in developing effective diagnostics, vaccines, and treatments. IVI's research into a leptospirosis vaccine brings hope to many nations battling this disease. Sri Lanka is eager to continue its collaboration with IVI and reaffirms its commitment to supporting these efforts in the future. Thank you.
Thank you, Dr. Dabrera. Turning back online, I'd like to invite the representative of Sweden, Dr. Johanna Rubin, to deliver remarks.
Thank you, Colin. And I did send some slides, but a bit late, so maybe you can just provide them for the colleagues by email. Thank you to all present directors and colleagues and to our hosts in Thailand. And again, sorry that I am online. I want to thank you, my colleagues at the Global Council, for your remarks and for your ideas for the future of IVI. And I've noted in Dr. Kim's speech, especially the initiatives on hepatitis C. And I will talk about the points that we were asked to talk about, dividing in first in Sweden's national initiatives in the vaccine area. So Sweden's government recognizes the importance of vaccination and prioritize vaccine-related activities both in Sweden and abroad. And Sweden has the last years reinforced the focus on vaccination, and during the COVID vaccine effort, actually there was an implementation of the HPV vaccine for boys in the national program, and also a national program for elderly for pneumococcal vaccine. And we have also started to conversion of the recommendations for BCG vaccine in children to establish a national program for this starting in 2025. And Sweden will invest in different ways the coming years in vaccine. We will invest in SWE trial, which is a new partnership to coordinate and enhance clinical trials. And we have also co-financed the development of a national innovation hub for manufacturing advanced drugs and vaccines called NorthX Biologics. And we have also invested in a research program on viruses and pandemics. And we finance the so-called SWE Life Lab with investment in laboratory capacity and know-how for future pandemics. And these are all ways and tools where Sweden might be able to assist the IVI in different aspects of their work. And in response to the Mpox emergency, Sweden has joined the global response with support to WHO and the Africa Center for Disease Control and other governments. And we have supported through central multilateral organizations such as Gavi and the Global Fund, UNICEF, and of course IVI. And we worked through the EU's joint response, and where we know that the first 99,000 vaccine doses out of a bit over 200,000 doses are announced to already have arrived in DRC earlier this month. And we also contribute to the work through the Vaccine Alliance Gavi. And we are active in the WHO response, not only in a monetary sense, but also to assist with the procurement, purchase, and distribution of vaccines against Mpox. And in September, Gavi signed an agreement with the vaccine producer Bavarian Nordic to secure 500,000 doses of Mpox vaccine in Africa. And in more direct ways, also the Public Health Agency of Sweden is now has now a study underway with a clinical trial for a first booster dose. And this is in cooperation with France, who will do immunological analysis in this research project. And it will be a mutual experience sharing project together with colleagues in the DRC. And Sweden has from the start employed a vaccine saving strategy with subcutaneous injections, and also not to burden to develop this new, but quite new and or not so well tried technique so far, but also to save doses globally. And on the point of strategic prioritizes for IVI, Sweden's political engagement is accompanied by our steadfast support to the principal health actors, and we stand by IVI's work with access to medical and non-medical countermeasures for prevention, preparedness, and response against health threats globally, and specifically with a focus on Africa. And we support IVI's continued collaboration with the Africa Center for Disease Control and the governments in the most affected countries, and IVI's work in all of the already established areas. And we also want to support a development towards countries' own capacity to finance and implement programs. And also we want to support the development of structures to share vaccines during a crisis. And we want to support IVI's work to increase access to important vaccines with evidence-based efficacy and where reasonable health economics are in place. So these are some of the, to highlight some of IVI's areas where you're already working, where also IVI, Sweden stand behind IVI in all these areas. Thank you.
Thank you, Dr. Rubin. At this time, we would like to invite the Kingdom of Thailand to deliver its remarks.
Good afternoon, Chair and Honorable Representative. It is my great honor to speak on behalf of Thailand, the critical importance to global health security. The need for the urgent investment in Mpox vaccine. As we are aware, Mpox has re-emerged as a significant public health challenge, with cases spreading across the country and outside the African continent. On 14 August 2024, WHO Director General has declared Grade 1B Mpox outbreak in DR Congo a public health emergency of international concern, a second time for Mpox in the about 2 years period. As of 31st August 2024, over 100,000 laboratory confirmed cases of Mpox, including 2,034 deaths, have been reported to WHO by 123 member countries. The actual numbers of cases and deaths are greatly underreported, and we need the effective vaccines. And the number of cases are still on the rise in African region and also some cases in Southeast Asia and Western Pacific. As we see on the slide that there are the active outbreak in some country. The top 10 country that show the highest number of cases in the last 6 months also include Thailand. The new cases reported weekly about 10 to 20. The first Mpox case in Thailand was reported in July 2022. He was the foreigner and imported into the country. The national surveillance system has recorded 842 laboratory confirmed cases over the past 2 years. The majority of those cases are concentrated among the young adult men, and many of them are living with HIV, which makes them particularly vulnerable to severe outcomes. It underscores the urgent need for effective vaccine and strategic approach for vaccination to protect high-risk population and prevent further spread to global population. Currently, Mpox vaccines are available to the high-risk population at the limited number of doses. The newly affected country with the Grade 1B virus also shown on the slide. We reported one case of the traveler returned from Africa to Thailand. Despite effort to contain the outbreaks, we continue to face several challenges. For example, increasing global spread of mpox and the vaccine shortage. Challenges in global coordination for affordable vaccines, limited access to vaccines and equitable distribution. Low and middle income countries face difficulty in accessing the mpox vaccines. Manufacturing bottlenecks and delayed distribution impacted outbreak response time. Supply of the vaccine for the high-risk group and vulnerable population is still needed, and public awareness of mpox remain low. Investing in mpox vaccine is not just a public health investment, but a strategic necessity for global outbreak prevention. Effective vaccine can significantly reduce transmission, especially in the high-risk population, such as those with immunocompromised hosts. I would like to share the recommendation to the IVI Global Council. First, enhance the effectiveness of the regional stockpile to improve vaccine equity and accessibility across the regions. Advocate for technology transfer and promote the sharing of lessons learned between regions to achieve vaccine equity and capacity building. Last but not least, support member countries in risk mapping and mpox forecasting by considering variant strains at risk population and changing social behavior to better predict vaccine demand and procurement needed. Thank you very much for your attention.
Thank you. At this time, I would like to invite the representative of the United Arab Emirates, Dr. Nada Hassan Al Marzuki, to deliver her remarks.
Mr. President, Chairperson, Excellencies, and distinguished representatives, good afternoon. First of all, we would like to thank Dr. Opart and the Ministry of Public Health in Thailand for their hospitality, wishing you all the best for the coming 2 years. Dear colleagues, we would like to acknowledge the work of the IVI and their effort to support countries and regions to bridge an end-to-end vaccine research and develop ecosystem with sustainable manufacturing. The need for vaccines, particularly in underserved populations, remains urgent. The COVID-19 pandemic and the current mpox emergency has underscored significant gaps in vaccine equity and access, revealing the unequal distribution of resources and health infrastructure globally. We support IVI activities on capacity building for R&D. We think this is a crucial area where IVI should support and continue to contribute to it significantly, especially by providing technical support and training in resource-limited settings, along with advocating for sustainable solutions that include technology transfer, regional vaccine productions, and policies that prioritize health access for all. The United Arab Emirates has made significant strides in advancing its national vaccine research, development, and manufacturing capabilities. By investing in cutting-edge research facilities, fostering partnerships with leading global pharmaceutical companies, and promoting innovation in biotechnology. In response to COVID-19 pandemic, UAE has integrated state-level emergency system with a whole-of-government approach, supported by high political commitment. And as a collaborative effort to meet the growing global demand for vaccines, Hayat-Vax vaccine was developed and produced under a licensing agreement with Sinopharm. This initiative of establishing a local vaccine manufacturing plant reflects the country's commitment to enhance self-reliance in vaccine supply. Moreover, UAE is supporting global efforts by providing significant medical assistance, including vaccines, to countries in need. For example, during the COVID-19 pandemic, and along with the national entities and international partners, the UAE has provided COVID-19 vaccines for countries in need. It has made significant contribution to the global distribution of the vaccine, particularly through initiatives like the HOP Consortium and the Dubai Vaccine Logistics Alliance. These efforts has facilitated the distribution of vaccines to over 135 countries, delivering millions of doses.
Another example are the efforts of UAE to support the End Polio Global Strategy by donating polio vaccines to epidemic countries to protect millions of vulnerable and hard-to-reach children. This also includes the provision of training to healthcare workers and facilitating access to immunization for children in remote areas. Since 2014, and through reaching the last mile, the UAE President, His Highness Sheikh Mohammed bin Zayed Al Nahyan, has given more than $376 million to global efforts to end polio and distributing more than 700 million vaccine doses. And more recently, the UAE has directed a $5 million to fund the delivery of polio vaccination campaign in Gaza following the re-emergence of the virus within the territory. Around 1.26 million doses of polio vaccine have been delivered to Gaza to vaccinate around 640 children, especially in the light of the widespread forced displacements and the extensive damage to the health system and water and sanitation infrastructure in many areas in Gaza Strip. Regarding Mpox, the UAE is playing a crucial role in addressing the Mpox emergency by swiftly implementing public health measures, raising the healthcare worker awareness in the country, and enhancing our activities and surveillance activities for early case detection. We also emphasize the importance of global cooperation. That is why we are working closely with the WHO to share data, expertise, and resources to understand more around this emergency. Furthermore, UAE supports Mpox vaccines delivery and it has pledged to send to 5 most affected African countries, the DRC, Nigeria, South Africa, Ivory Coast, and Cameroon, in the near coming weeks to combat the outbreak of the virus. So through the international aid, collaboration in research, and support for vaccine equity, the UAE encourages the solidarity and collaboration between countries of the world, since it is the key to mitigate any future risks. Lastly, this time is the best time to collaborate at all levels and rethink and redesign the mitigation strategies to handle the vaccine-preventable diseases and any pandemics in the future. We encourage IVI to focus on different areas in an innovative way and suggest the following as strategic priorities for the coming 2031 plan. First, focus on research and vaccine development, especially at local level, and support the vaccine clinical trials, evaluation of vaccine effectiveness, and post-market studies. Second, invest in e-health systems such as electronic platforms and smart applications. The availability of the digital infrastructure, healthcare data, and electronic systems are highly important to support the planning, analysis, review, and decisions, and provide a timely and accurate data through dashboards and databases. Third, to strengthen the global collaboration among scientists and assist in developing new strategies and technologies and help to implement a more green manufacturing. Last and not least, to adopt One Health and multi-sectoral approach strategy beside health and all in the planning and developing of the needed vaccines to combat any future pandemics and re-emerging diseases. We in the United Arab Emirates will continue to support the global efforts and IVI, and we confirm our commitment to combat outbreaks, build the capacities, strengthen the preparedness for a future health crisis, ensuring an equitable access to vaccines all along. Thank you.
Thank you, Dr. Marzuki. At this time, we're going to have remarks from the representative of Uzbekistan, Dr. Nurmat Atabekov. Dr. Atabekov will deliver his remarks in the Russian language, and the IVI Global Council Secretariat will provide a translated transcript of those remarks as soon as they are available. Dr. Atabekov, please. Yeah, хорошо. Пожалуйста.
Добрый день, уважаемые коллеги. К сожалению, мой английский очень слабый. Ну, знаю я русский, турецкий, узбекский, казахский языки. Но вместе с этим хочу сказать, в Узбекистане 38 миллионов населения. И у нас вакцинация идет против 13 видов инфекционных заболеваний. И охват вакцинации ежегодно составляет 98-99%. Хочу сказать, что в Узбекистане первые годы независимости была вакцинация всего против 6 видов инфекционных заболеваний, на сегодняшний день 13. Во время пандемии коронавируса было доступно 8 видов вакцин. 2 вида вакцин были отечественного производства. Хочу сказать, что у нас было провакцинировано более 22 миллионов населения. Вакцинация была начата 1 апреля 2021 года. Хочу сказать, что я являюсь одномоментно руководителем Национально-технической экспертной группы по иммунизации, и мы готовы к внедрению новых видов вакцин, если таковой рекомендуется со стороны Всемирной организации здравоохранения и международных экспертов. Еще раз, я очень благодарен. Я надеюсь, что при следующей встрече я уже буду говорить на английском языке, потому что вынужден изучить английский язык. Спасибо за внимание.
Okay, good afternoon, everyone, and welcome to session 3. We begin session 3 with a summary of Global Council representative remarks. I would like to invite Dr. Douglas Schaefer, Deputy Director General for Global Affairs and Communications at IVI, to present the summary. Please welcome Dr. Schaefer.
Thanks very much, Colin. Honorable representatives, Global Council President Dr. Opart, distinguished guest, Director General Kim, and colleagues, my name is Douglas Schaefer. As Jerome shared earlier, I had the honor to join IVI less than a month ago. And I have the opportunity to work with the phenomenal Global Affairs and Communications team, which have been supporting this effort, including rushing to pull together some of the highlights of themes and recommendations that we heard from the Global Council. We will be sharing minutes with finer details. However, given the remarkable comments and thoughts shared by the Global Council, we wanted to reflect on some of the recurring themes and specific recommendations. A few of the recurring themes we heard include capacity building, whether that be training, clinical trials, or regulatory, the importance of technology transfer, the importance of keeping in mind the concept of universal health coverage, the critical importance of vaccine equity and access, establishing vaccine reserves and stockpiling where appropriate, the importance of regional hubs for self-reliance, and international collaborations. We appreciated the country updates on MPOX, including epidemiology and surveillance, early vaccination efforts, and key initiatives, including mapping high-risk populations. A few of the specific requests we would like to reflect upon include developing vaccines using new technologies that are also compatible for use in low-resource settings, building local capacity and infrastructure, creating research funds and hubs, supporting that we appreciated support for IVI's observer status at UNGA and the World Health Assembly, and certainly the importance of continued advocacy efforts on the global stage. Last, we also appreciated the importance of maintaining a One Health perspective, and we're certainly eager to continue those discussions as we think about support in the prevention and elimination of diseases such as leptospirosis, Rift Valley, and MERS. So again, huge thanks to all of the Global Council members that took time to give us their updates on their current policies and strategies and recommendations. As I shared, we will be forwarding the detailed minutes with all the comments, but we did want to reflect on some of the comments and share our appreciation again. Thank you very much.
Thank you, Dr. Schaefer. In this next segment, we will discuss the need for adding leptospirosis to the World Health Organization's neglected tropical disease list. To begin, I would like to invite from the Kingdom of Thailand's Department of Disease Control and the Ministry of Public Health, Mr. Tirasak Chuksnum, to deliver his presentation.
Good afternoon, Chair and participants. This afternoon, I would like to emphasize of the leptospirosis that is burden of in the global world, and also the representative for the WHO. The key point that I would like to present is for the first one is what is leptospirosis, economic health and social impacts, challenges in the managing the leptospirosis and recommendation for the global strategies. For the leptospirosis, it's a zoonotic disease caused by bacteria of the genus Leptospira. And Leptospira have many genus and affected with the various of the species of the animal. The transmission contact with the water contamination by the urine and the infected animal. This can prevent prevalent in the tropical and subtropical region, particularly the population in poor sanitation and integrate of infrastructure. The sign and symptom has very various from the mild and also from the severe complication, including the fever, from fever to acute renal failure, jaundice, hemorrhagic manifestation. Severe cases can progress of meningitis and also severe pulmonary hemorrhage and acute respiratory distress. For the economic and health and social impact, and you can imagine that the estimate of the cases around the world is 1.03 million, and it's nearly 59 deaths annually around the world. The impact can be happen in the vulnerable population. For example, farmer and people who are living in the slum or flooding areas, and it's need to be the One Health approach to be solve the problem between human, animal, and environment to coordinate and integrate indicated control and prevent efforts. You can see that the leptospirosis significantly distribute in the global diseases, and we found that estimate 2.9 million disability at just life year or daily can be happen. And the management of the severe leptospirosis cases heavily depend on high dependency of the intensive care, including during outbreak of foreign environmental event, for example, from the flooding and also the rainy season. This is what we found for the impact of the diseases, particularly in the low and middle income countries where the burden of the disease happen especially in the Asia Pacific regions and China, Thailand, Indonesia, Sri Lanka, and also in the some area, for example, in the island. This is the most important area of the burden, and this is what we found from the lost productivity among these areas. We found the challenges in the managing of the leptospirosis. The first thing is under-reporting and lack of accurate surveillance. Because of the diseases have various from the mild to the severe symptom, they may found under-report in around the world. And this is what we found that the insufficient diagnosis capacity. For example, they need the screening diagnostic capacity and challenge with the current vaccine strategy, for example, in animal. And as I have mentioned before, that leptospirosis has various in the various of the silurwas and in the specific various of animal species. This is vaccination strategies in the animal is very important, and also need the development of vaccine in human. The address of the social determinant of health need to be combined and integrated among the One Health strategy, because we need to control and need to survey from the environmental situation, especially among the environmental event, for example, in the crisis of the flooding. The recommendation of the comprehensive global strategies. First one, leptospirosis is neglected global health priorities, is significant for economy and social determinants and consequences. Secondly, improve the surveillance and diagnosis in the global and local level is needed, because of we need to strengthen the surveillance to do with the under-report of the leptospirosis. The prioritizing in the vaccine development is needed in human and animal, and One Health approach is essential for prevention and control. We need the control measure in animal and also the environmental among the crisis. And lastly, prioritizing leptospirosis within the WHO in neglected disease framework would be eliminated. With important with potentially lead to the target global initiatives. So this one, I would like to conclude that the leptospirosis is one of neglected tropical disease that we need to encourage and also to be posed in the global strategy. Thank you very much.
Thank you, Mr. Tirasa. At this time, I would like to invite Dr. Suneth Agumpodi to provide a presentation on leptospirosis from IVI. Thank you.
Thank you, Colin. Distinguished Global Council members, all invitees, my colleagues from IVI, I would like to expand on what presented by Ministry of Public Health Thailand, and I'm really thankful for Thailand to take these initiatives. And as IVI, we are here to take this momentum forward and then try and get leptospirosis on NTD list of WHO. Where's the slides? This one. Thank you. So I will expand on what already mentioned, but before I explain this, I would like to highlight key points in relation to this issue. First one, leptospirosis. I think for people who are sitting here, most of us, we know that it's a major public health issue in this part of the world. And then the problem is that in some areas, even though the problem is there, it's not recognized and it's underestimated. And most importantly, it's disproportionately affect vulnerable population, marginalized population, urban poor, and rural communities. And leptospirosis is often neglected in research and development. I will explain why it is neglected. We don't have proper diagnostic tests, we don't have proper vaccines, and we don't even have proper clinical guidelines for leptospirosis. I will explain why there are no, why we are having all these problems. And then it's a part of poverty and socioeconomic development, especially in areas where they have these issues in poor communities. And also it's amenable to public health interventions proposed by WHO in combating NTDs, which is a requirement to include a disease in NTD list of WHO. Leptospirosis, coming back to the disease description, it is considered as the most widespread zoonotic disease and endemic in more than 150 countries. And more than 1 billion people are at risk of acquiring leptospirosis, and this number will go up with climate change, and even 0.5 centigrade change in temperature will increase this number. And working as a physician, to provide you my background, I was working in Ministry of Health in Sri Lanka for 6 years as a primary healthcare physician, working in hospitals and then in community as community physician before joining academia as a public health physician. And during that time, and I know that some of you who has worked in tropical areas, it's always a clinician dilemma when you are having a fever patient, because you are having so many tropical diseases and you don't have enough resources for diagnosis and you don't know initially what you are dealing with. So there are so many diseases mimicking leptospirosis. It may be malaria, dengue, typhus, or other rickettsial diseases, but it's very difficult to come to a diagnosis. And because of this problem, clinical suspicion is low. And when clinical suspicion is low, the disease epidemiology is not well described, and diagnostic facilities are not available. So it will lead to underdiagnosis and underestimation of disease burden. So what will happen if you get a critically ill patient with leptospirosis? And today during lunchtime, our Director General was mentioning he was working in a hospital where there are leptospirosis. It's not that common in USA, but it is there. And when you get a patient with leptospirosis in your intensive care unit or critical care unit, it is really difficult to manage this patient. Because at that time, when patient comes to hospital with organ failures, usually antibiotic will not work because the patients are in immune phase. And then you need all the supports that you can provide, which is usually not available in tropical settings or poor countries where the disease is endemic. So during outbreaks, what we have seen in Sri Lanka, the same thing happening in Thailand, Indonesia, Malaysia, Fiji, Brazil. What happens is there's high bed occupancy in these hospitals and diagnosis is not available. And you need close monitoring, you don't have enough facilities and fatality rates are high. And multi-organ failure is very common if you don't have enough facilities. So the problems are multifaceted related to leptospirosis. You have poor clinical suspicion, lack of diagnostics, weak surveillance system, and poor global, regional, national recognition on leptospirosis, which is leading to gross underestimation of disease burden. And on the other hand, there are no effective chemoprophylaxis, and antibiotic treatment is uncertain. I will come to that later. And clinical management guidelines are not optimized and no vaccines available right now. So this will lead to poor patient outcomes. And if you look at the picture of leptospirosis, there are so many areas neglected and we need answers. So coming back to underestimation of disease and lack of proper data on disease burden, it's a vicious cycle. If you're a clinician, you have to have an understanding on disease epidemiology to suspect the disease. And if you don't have the understanding, your clinical suspicion is poor. This is very common in settings where you are working in a different type of leptospirosis. Now, as an example, in Sri Lanka, a physician working in southern part of the country might have this patient diagnosed as leptospirosis if they are having pulmonary hemorrhage, lung hemorrhage. But another physician working in North Central province might consider a patient with kidney failure as leptospirosis, because leptospirosis can present in so many different ways. And then when there's poor clinical suspicion, you need diagnostics, but there are no point of care diagnostics, and it leads to missing patients. And in endemic countries, tropical countries, usually the health system are not that good. We don't have computerized or digitalized patient information system, and surveillance is weak, and it leads to gross underestimation, and this is a vicious cycle. And this is happening again and again in leptospirosis. And why it is a different clinical diagnosis? These are 4 examples which I have encountered and which other people are encountering again and again in different parts of the world. So you might get a patient with a severe abdominal pain, and from the admission office, this patient may go to a surgical ward rather than a medical ward, giving a diagnosis of acute abdomen. But leptospirosis patient may present with acute abdomen if they are having pancreatitis. And we have encountered this, and once you diagnose one patient, then people start suspecting similar patients and diagnose leptospirosis pancreatitis. And within a month, we have seen 6 patients with pancreatitis, which are usually not labeled as leptospirosis. Same thing happened with viral fever patients, an outbreak of viral fever, and then you go and see these patients, and another physician interested in leptospirosis just wanted to see whether this is leptospirosis, and you end up with having a leptospirosis outbreak. And you can get patients with confusion, which might even go to a psychiatric ward if the patient is not having fever, but it may due to leptospirosis meningitis or encephalitis. And we have seen 5 patients within one outbreak with the same symptom. and patients may come with faintishness or symptoms showing some heart conditions due to leptospirosis, myocarditis. So the problem here is that usually physicians think, most of us think, a leptospirosis patient is a patient who is having yellow eyes, that is jaundice, or red patches in eyes, conjunctival hemorrhages, and having fever and enlarged liver and spleen. But this is only a small fraction of leptospirosis, which was described more than 100 years ago by Wills. And this so-called Wills disease is only a small fraction of leptospirosis. And if we look at textbooks, still textbooks are referring to this type of patients for leptospirosis, which misguides our diagnosis and clinicians and physicians. And if we can't do this clinically, then we should have diagnostic test. The test we are using, the standard diagnostic test, or the diagnostic test which was considered as gold standard for more than 70 years, is difficult to perform, and it's resource intensive, and it has very limited clinical use because you will always get negative results within first 5 to 7 days in MAT. You will get positive results after 7 days, sometimes after 10 days. And it has a poor sensitivity. Recent studies, more than 10 studies, shows that the sensitivity may be around 50 or 60%. Then we have ELISA-based methods. There are about 10-15 different ELISA-based methods commercially available. But the problem of these ELISA-based methods, they are using MAT as the gold standard diagnostic test. And the validation is based on MAT. And if MAT is not having good sensitivity, of course, these ELISA tests are not that good. Then we have culture, which is extremely difficult. If you try culturing leptospira, you will get about 5 to 10% positives. So one of my studies, when we were doing it in 2017, out of 1,500 samples, we got only 25 cultures positive. So it's extremely difficult. qPCR is the best available diagnostic test right now. But even with qPCR, you might miss at least 40% of leptospirosis patient. And qPCR, again, you might not be able to provide qPCR test in most of the places where the leptospirosis is highly endemic. So if you look at this performance of this diagnostic test, the best one is whole blood qPCR, and you can confirm only 60% of the cases. So this particular study was done using more than 1,500 samples, and you can see none of the diagnostic tests are performing well, and the best one is having only 60% sensitivity. So the diagnostic is a major issue in leptospirosis, and this is why we say it's neglected in research as well. And clinical diagnosis of leptospirosis is misguided not only by clinical suspicion or lack of diagnostic, but it is based on available literature as well. Most of the published literature in these studies, when they recruit patients, they use selection criteria based on original description. So they will end up having those patients who are having typical leptospirosis with jaundice, conjunctival hemorrhage, and all the other classical symptoms. And when they publish it, they will publish it as this number of patients are having these symptoms. 60% of our patients are having these symptoms, or 70% of these patients are having these symptoms. But it is biased because the selection criteria include those symptoms. So the clinical description available in published literature is also problematic, and it is misguiding this diagnosis. So that's why we call it a vicious cycle leading to underdiagnosis of patients and gross underestimation of disease burden. But with all these problems, even though all these problems are there was one study published in 2016 trying to estimate the global disease burden. And the study was using routinely collected data from countries and published literatures But the problem is that all these things are a gross underestimation. Even with this underestimated numbers, there are more than 1 billion at risk and 1 million cases worldwide requiring hospital admissions. Now, these are moderate to severe cases, not mild cases. And then estimated 58,900 deaths based on these estimates. So it's not a small burden. If you look at what really happens, if you look at the proper literature where they have done longitudinal studies using community or population-based samples, the best example comes from India. And there was one study showing that according to the current global estimate I already showed, the disease burden is about 10 to 24 per 100,000, India's disease burden. But this particular longitudinal study shows that the actual disease burden may be around 89.5 to 7,198 per 100,000. Because they were testing all these patients, they were testing all viral fever patients and mild infections, and the numbers were much higher than the global estimates. And based on that particular study, it is estimated that India alone might be having more than 1 million cases per year if you are to count all mild cases and seroconversions. And the same type of studies were done in Iran, Nepal, Sri Lanka, Brazil. All these longitudinal studies shows that the actual disease burden may be around 10 times or even more higher than the global estimates. And last 20 or 30 years, if you look at literature, and there's a published systematic review on this one, there's an increasing number of outbreaks of leptospirosis globally. And if you look at the map, you can see, even though it's a tropical disease, most of the investigations are not from tropical disease. So this is because of research bias. So if you get people visiting tropical areas and going back, let's say leisure activities, you will always investigate and publish the paper. So that's why you have more publications from Europe than Africa. So this is again not representing countries where they have actual disease burden. More than 100 outbreaks are reported annually, and more than 20% increase of the case numbers even in EU region last 10-15 years, and even USA, they are reporting increasing number of leptospirosis cases. And there are studies showing that it is one of the few communicable diseases increased during COVID-19, and we don't know actually what was happening. Now, as an example, one study in Sri Lanka, it shows that during COVID-19, people can't go to work, so they went on farming, which increases the risk of leptospirosis. And based on the previous 2016 disease estimates, incidence and morbidity and mortality estimates, DALYs were estimated for leptospirosis. Again, this is based on suboptimal data. There are more than 2.9 million DALYs lost annually. And of those, 50% are men in between 20-49 years in tropical regions. And these are the breadwinners of these families. And leptospirosis is affecting families, poor families, their breadwinners, and leading to economic crisis in these families. And if you look at these DALYs, if you compare these DALYs with other NTDs included in WHO NTD list, and this is without the big three diseases, malaria, HIV, and TB, you can see leptospirosis in red. The disease burden is much higher than at least half of the diseases listed in WHO NTD list. And this is again grossly underestimated. And if you look at the economic burden, again, there are only few research done on economic burden of leptospirosis. One from Latin American region, they estimated 7.8 billion loss due to leptospirosis. This is direct hospital, direct and indirect costs in Latin American region. It's $7.8 billion US loss. And other studies from New Zealand and Vietnam also shows very high economic loss due to direct cost, hospitalization, and treatment cost. And then we did another study based on the previous published data, 2016 data on productivity loss of leptospirosis. And if you look at the productivity losses, and I would like to point out that the top 10 countries having highest productivity loss due to leptospirosis, and if you look at those countries, except United States and Japan, all the other countries are IVI member states. So we are representing countries who are having the highest impact of leptospirosis. And in China, the burden is around 5,000 million US dollars. And India, again, around same number. And then Sri Lanka, Thailand, Vietnam, Brazil, Malaysia, all these countries are having very high economic burden. This is not the hospital cost or treatment cost. This is only the productivity cost. And leptospirosis is especially a challenge even for clinicians, physicians, and scientists who are involved in research, because the knowledge on this disease is rapidly changing. If you can remember, those who are not aware of leptospirosis or not discussed leptospirosis recently, you might remember that the disease is caused by Leptospira, which has two species, Leptospira intergens and Leptospira biflex. And this is what I learned in medical school. But then when it came to 2015, people started studying different genotypes. And by 2017, there was 10 pathogenic species, 6 intermediate species, and 8 saprophytic species. And it changed rapidly. In 2019, it has gone up to 13 pathogenic species causing leptospirosis. In 2020, 19 pathogenic species. Now, it's going to be 22 pathogenic species. The paper is not published yet. So this is only the Leptospira pathogen. But knowledge on disease is also changing. We thought that it is only immune phase that we get all the disease, but recent investigations shows that the VM protein or virulent modulation protein is having a major pathogenic changes in the body, and the severe cases may be even in the first week of infection. And if you look at the evidence available on chemoprophylaxis and antibiotic treatment, there are 2 Cochrane reviews published in this year, 2024, and both Cochrane reviews, the conclusion says that the role of antibiotics for treatment of leptospirosis is uncertain, and role of chemoprophylaxis in preventing leptospirosis is also uncertain. The major problem is for both systematic reviews, there are only few clinical studies or randomized controlled trials conducted on these specific issues, again due to lack of funding. And leptospirosis, being a zoonotic disease, it needs a true One Health approach, because disease is usually transmitted to wet soil, and people get this disease most of the time, more than 95% of the time, through the environment. And all mammals, marsupials, and birds can harbor leptospira. So if you look at the living conditions in most of the parts of the world, the disease is there, leptospira is there, the environmental condition is there. The only problem is that we are not diagnosing this disease. So you have to have not only diagnosis for and preventive activities for human leptospirosis, you have to have One Health approach controlling animal leptospirosis as well. And this is a particular problem in countries like New Zealand, Australia, UK, and some of the European countries where they have large farms and people are working with these farm animals. So this is a major animal health risk. All these mammals can get leptospirosis, but at least for animal leptospirosis, they have vaccines, maybe not effective, 90% effective, but at least 70 to 80% effective. And it's a global health with current problems in climate change. So what happens in what happens with climate change, you can see the disease is transmitted through environment. In all these countries, not subtropical countries and other places also, the animals, mammals, marsupials and birds, they do have leptospira and they shed leptospira to the environment. But they can't survive in the environment because the temperature and the environmental conditions are not good. With the climate change, with increasing temperature, the environmental conditions will be suitable for leptospira and the disease will start spreading to subtropical areas and other countries as well. So this is going to be a major global threat with climate change. And of course, deforestation, unplanned urbanization, and improper solid waste disposal, all these things will contribute to increased disease burden. So coming back to WHO NTD list. So this is a list of 20 diseases, mainly prevalent in tropical areas, and mostly affect more than 1 million people. And usually these NTDs complex, often related to environmental conditions. Many of them are vector-borne, have animal reservoirs, and are associated with complex life cycle. This is the definition in WHO site. And if you can see, this definition clearly fits into leptospirosis. And it is not still in the list. And how do we can push WHO to get, what should we do to get this disease into WHO NTD list? It was not very easy to get all these guidelines, but if you look at the process clearly, criteria for classification as an NTD, we have to submit a dossier to Strategic and Technical Advisory Group for Neglected Tropical Disease, STAG recommendations for the adoption of additional disease as neglected tropical disease. So they will have their committee meeting once a year and they will go through 4 different things. First one, disproportionately impact on poverty. Then geographic prevalence, we should have a compelling data on disease incidence and prevalence. Amenability to public health interventions, they have 5 interventions mentioned in the website, and neglected by research and development. And if you look at all 4, and if you look at what is happening right now, leptospirosis is fulfilling all these 4 criteria. And the process, there should be endemic country preparing this dossier and they should make the request. And it should go to the WHO country office. And from WHO country office, it should go to the regional office. And from regional office, they will send it to WHO Department for Control of NTDs. And WHO STAG NTD will review the dossier and then they will send their recommendation to Director General for endorsement. So this is the process that we have to follow. And now, realizing what is happening and looking at the country's problem, Thailand is also already working on this. And Sri Lanka, they guaranteed the Secretary of Health that they will take this forward with IVI support because we have to prepare this large dossier with all the evidence available. But this dossier should have a cover letter or a document summarizing all this evidence. And this document should have other countries, at least 10-15 countries, endorsing this proposal. So this is where we all comes in, all these countries, the IVI member countries. So this is just to describe why it should be there. And this is addressing WHO criteria to be included in NTD list. And we are preparing this dossier. As you can see, most of the countries, our member states of IVI, they are having very high burden of disease and most of the countries are aware of this disease burden. What we request, our pledge is to our member states to signatories of the proposal. So we request your support. So Thailand and Sri Lanka will make this forward. IVI will support dossier preparation and then all the background support they need. But we need countries to
events. So in order for seeking this observer status, IVI will need to prepare an official application to both WHO and UN, and then reviewed by the by the WHO and the UN, and then with the consultation of the member states, then when a draft of resolution for supporting this IVI observer status is drafted, then it will be put as a resolution item at the World Health Assembly and the UNGA. So this process may really take time, and then IVI also will need to have a direct discussion and negotiation with the WHO and UN. And when it put as a resolution item, then the decision making will be made through the majority vote. So thinking, the number of the WHO and UN member countries, half of majority vote means that at least almost 100 or over 90 countries should support this initiative. So currently we have 26 state parties, and we really need, all of our member states support for this, and also your advocacy within your region and your ally countries to support this initiative. So once when IVI, gaining this observer status at WHA and also UNGA, IVI has can contribute participate in the those policy discussions, and such as this LTD, putting the lepto into LTD, and many other key vaccine R&D and manufacturing initiative and high-level policy making. So in that sense, we would like to seek all the member countries' support for this, and through the next global council meetings, we'll keep updates on our progress, and then we'll seek your support for that. Okay, so another business we wanted to raise is it's kind of a heads up. GC presidency in 2026 and 2027. So this June, when we had a virtual global council meeting, we had the GC president has been nominated, and with the support from the Ministry of Public Health of Kingdom of Thailand, Dr. Opart has been appointed as a president of the Global Council this year and then next year. So next year, there will be, at the GC meeting, there will be either election or nomination of the next presidency, because in our rules of procedure says that first president can start from any region, and then it follows by rotation based on the alphabetical order of WHO's region. So the first presidency came from the Southeast Asia region, 0. Then the next alphabetical order is Western Pacific, so WIPRO. So at WIPRO, we have the Philippines, Korea, Vietnam, and China included in this WIPRO region. So, next year we'll discuss whether there's any countries who willing to take this presidency role among this WIPRO region, or in case there's no volunteering countries, we can also consider, revising the rules of procedure, removing this alphabetical order, so that any country from any region can, take up the role of next presidency. So we'd like to, at the next GC meeting, we will discuss all these matters, and then internally within your government, we would like to request your internal discussion on this matter. Same thing for the World Health Assembly and UNGA observer status, because we need your government support, and at the these meetings there will be voting, and then representative of the delegation will make a final voting. So that's why we need our GC representatives support on these matters. So in case you have any questions, please.
We recognize Pakistan.
Thank you so much. I'll just revert to your first slide. I think that's an excellent thing to be on the observership of WHO and UNGA. In order to highlight, because as you say, we understand, you need a good number of countries. So one of the good modalities is there are side events, as we all know, with Anga. Has IVI scheduled any such side event previously or plan to do, because that will truly highlight a number of countries can see what IVI is doing. So we would strongly suggest that. It has recently been done, so maybe the next year should be the great target.
Yep.
Thank you. Thank you so much.
Thank you very much for your valuable suggestion. We actually got the WHO the observer status from 2023 with the support from Dr. Anders Nordström sitting here, and also with the support from the government of Korea. However, our status was part of the UNDP in case of World Health Assembly, because IVI is originally initiative of the UNDP. There was some limitation, however, in securing number of the seats available for this observer status. That's why we wanted to independent status. And then in 2023 and this year, we organized side events. So in 2023, it's about the global local biomanufacturing strengthening. And then we have 6 or 7 countries, joined as our co-sponsoring countries, including Korea, Brazil, Kenya, Ghana, several countries. And this year, we also organized another side event regarding the AMR. And we had actually 2 events together with the Korean government as well. And next year also, Jerome has planned, we have another side event focusing on the strep A, group A strep. So we are considering to engage more governments, in co-organizing this event. And as you recommended, we will keep working on all those side events and raising awareness about IVI's activities and etc. during the World Health Assembly.
Thank you so much. That really sounds great. Just giving you one example. Through the World Health Assembly, we prepared a document on related to biosecurity, and we started working on different governments much before. So already you're into it, and you are planning for the next year. So I think you need to side by side focus on, with the presidency under Thailand approaching the different countries, consulates, and that would be again remarkable. But great that you are already concentrating on the side. Thank you so much for that.
Thank you so much for this advice. Yes.
Thank you. The Secretariat recognizes the United Arab Emirates. Please.
Thank you, and thank you for showing us the next steps that you are going to have. Just quick 2 comments that help the IVI go through. The visibility is very important. IVI is still not that visible on the global radar, and even if we are mentioning to our like colleagues in other regions, they don't know much about it. So visibility and the side events is very excellent. In October, this October, all the regional offices of the WHO will have their regional meetings. So I think this is a very good start since UNDP is part of the WHO, the UN, and they can request a side event within the RC meetings to get visibility of IVI. Another important thing is COP, and because climate change and One Health affecting lots of things, and vaccines is really residing at the heart of that. So COP, I think, is another event where UN agencies are represented there, and maybe you can be there. Lots of activities are going. As you know, in last year we started the Health Day. This COP have Azerbaijan is also hosting a human capacity day within it is health. And then in the COP30, Brazil is taking it forward. Brazil is one of the members here, and I think this is a very good case that you can build up the visibility. As well as Brazil and the G20 and the BRICS health group, and that is another important group that you need a visibility. And another comment is just about the presidency, and you said about waiving the alphabetical order. I think no, just keep it, but go like region by region. So to see who will be like preferably wants to be elected as the president. Thank you.
Yeah, thank you so much for your valuable recommendation. Definitely, in the following, Global Council meetings, we will update you on our progress, and also we wish to, share those events organized together with our member states. Thank you very much. Yeah.
Are there any other comments on what has been presented? Okay, seeing none. Thank you, Youngmi.
Thank you.
At this time, I would like to invite Dr. Douglas Schaefer to lead the discussion on the location and agenda of the 2025 Global Council meeting.
Thank you, Colin. Honorable Representatives, Global Council President Dr. Opart, distinguished guest, Director General Kim, and colleagues. On behalf of the Global Council Secretariat, I would like to thank all the Global Council and all participants who contributed to our meeting today. I thank Global Council President Dr. Opart for his commitment to open today's meeting prior to attending a high-level governmental meeting and return to continue overseeing our meeting. Our 2025 IVI Global Council meeting will come quickly. We would like to hear from you as we begin planning consistent with Youngmi's engagement with the Global Council. There are two topics that we welcome feedback and discussion on at this time. First is the potential dates and locations. We have considered May 8th and May 9th at the IVI headquarters in Seoul. This would be back-to-back with the Board of Trustees meeting May 7th and May 8th. We've also considered between May 19th and May 27th in Geneva during the World Health Assembly, which could be consistent with some of the discussions around visibility. And we certainly welcome any additional alternative dates and discussion. So Colin, perhaps we can open the floor, and we really welcome and invite any comments on this topic.
Thank you, Douglas. Are there any perspectives on the location for the 2025 Global Council? Any preferences? Recognizing United Arab Emirates.
Thank you. And looking into the proposed dates, maybe the WHA dates will be more preferable since most of us will be in the WHA, and it will enhance the visibility of IVI with the WHA, and I think this will support the case for having an observer seat. So, thank you.
Thank you very much for that excellent comment. Again, that's certainly consistent with your wise advice earlier. Thank you.
Thank you. Yes, recognizing Pakistan.
Thank you so much. I would sort of echo the same, because this is the thing, that strategy that we have, because I think we need, this morning we said the homecoming. So I think it's better, the more you're visible, the more you're vibrant. So we would suggest the same exactly, that a side event with the World Health Assembly would highlight to a much, and then side by side you have the UN office as well. So it will give you a much bigger exposure. So I would totally second that. Thank you.
Thank you. Recognizing Thailand.
I think the date of the 8 and 9 isn't so good because back to back the meeting and we move to the WHA again. Yeah.
Thank you.
So thank you very much for that very helpful advice and recommendations. We do want to invite any additional thoughts about potential dates or locations from the Global Council before we move on to discuss some of the agenda topics. So we certainly are open. We appreciate the great feedback, and we welcome any additional thoughts or recommendations as we consider the date and location.
Thank you. Recognizing Kenya.
Thank you, Doug, for the remarks. I think for me and for Kenya, it's to share the experience of organizing a side event next to a big event. The IVI, Government of Kenya, and the Africa CDC organized a side event during the Africa Union Heads of State meeting in Addis. That raised the profile of IVI immensely amongst the heads of state. We had a breakfast session and we had about 7 presidents attending. So I'm supportive of the proposal from the United Arab Emirates and also from Pakistan to consider having the side event at the WHA. Thank you.
Thank you. Thank you. Are there any other comments or suggestions? Okay, then, seeing none. Thank you, Douglas.
There's one other.
Oh, there's one other
topic,
agenda item. Yes, please.
If we can bring the slide back up. We would also appreciate your thoughts and recommendations on agenda items. We've listed several to consider, including nomination or election of the Global Council President for 2026 and 2027, any revisions to Global Council rules and procedures, updates on IVI strategies and priorities, and certainly any other recommendations on the agenda. So we would welcome any thoughts and recommendations as we think about an agenda that is responsive to the priorities and needs of the Global Council and our partners.
Yeah, so please let us know if you have any recommendations for the agenda of the 2025 Global Council. You can, of course, take this back to your government for feedback and consultation. And if you have any recommendations, you can contact us at any time.
Absolutely. Thank you. And just a last opportunity, as I mentioned, we wanted to engage the Global Council on both the location, date, and potential agenda items. Are there any other topics or recommendations the Global Council would like to make as we begin planning for the next meeting?
Yes, recognizing United Arab Emirates.
Thank you. I think if you can prepare a very short biography or to say about the IVI, where the GC council members can use, to advocate for IVI, that will be very much helpful. Now we do it on verbal basis and refer them to your website. But if you have something solid and like a PDF or something, a short biography, it can help a lot. Thank you.
Thank you very much for that excellent idea. I think it links to our increased efforts to as you mentioned, visibility, but really some focus efforts on increasing our communications as well. Thank you very much.
Are there any other comments or suggestions? Seeing none, I think we can wrap up your section, Douglas.
Thank you very much.
All right, thank you. At this time, I would like to invite the Global Council Presidency to deliver the closing remarks.
Thank you. Distinguished delegates, ladies and gentlemen, I would like to take this opportunity to express my gratitude to the member of IVI Global Council, representative from IVI Board of Trustees and IVI Global Advisory Group of Experts, as well as IVI Secretariat team for your remarkable effort in making this meeting a success. During this special meeting, We have discussed several topics such as IVI activities in Africa, the MPOX, collective response as the global cooperation, and the importance of leptospirosis as a global challenge. Thailand fully supports the IVI movement to drive leptospirosis, a global forum. In particular, for an effective prevention and control of leptospirosis using public health and social intervention including vaccine. This is highlighting our commitment to tackling this significant public health issue. In addition, the meeting has also been an excellent platform to discuss our vaccine strategy and recommendation for vaccine development and innovation, which will be a great input for IVI to drive further and manage it into the reality. With our strong commitment and effort, the discussion on this occasion is an overreaching step in enhancing and strengthening the whole system of global vaccine development that will ultimately protect the population and our global community. Your insights into national vaccine strategy and capabilities are vital as we seek to enhance vaccine equity, access, and capacity building for research and development. To this end, thank you very much for your active participation. I wish you all a fruitful upcoming site visit tomorrow and a pleasant time in Thailand. Thank you so much. ขอบคุณครับ